I'm so blind, I cannot spell the O. Then I'm like similar.
Good morning, everyone. My name is Dr. Nondembiso Magida, a lecturer at the University of Pretoria, and I'm specializing in physiotherapy. I have completed my PhD at the University of Witwatersrand, and I am working as a lecturer and more dealing with community rehabilitation. I am one of the colleagues in the JBI of Ekurhuleni. I'm happy that I am gonna be one of the sharing this session for today, and I welcome our colleagues from India and South Africa. I hope everybody is here, but I see we only have 15 currently, but you are all welcome. Thank you so much. But the person who's going to welcome for us is Dr. Edith Madela-Matla. I don't see if she's here. Is she here?
She's not here yet. Maybe give it a few more minutes.
Okay. Should we give it a few more minutes? Is someone have her contacts that she can call her somewhere? Because she's the one who's supposed to be welcome.
I don't have her phone number, but she just responded to the email. Thanks very much for the link. Just now, maybe 5 minutes before.
All right. Let's give it a few minutes and then we can start.
I have tried to get in contact with Edith. I don't know if she perhaps has load shedding or something. I'm thinking that oh, Edith is there. Thanks.
Oh,
Hey,
good.
I just went into load shedding and everything just shut off at 10 o'clock.
Okay, thank you, Edith. Let me quickly introduce you. This is Dr. Edith Madela-Matla. She is currently working as a senior lecturer and a researcher at the Department of Family Medicine at the University of Pretoria. And she's also a researcher, which is affiliated with the University of Pretoria Community-Oriented Primary Care. She has completed her PhD in mental health. Over to you, Dr. MANT.
Thank you very much, Chairperson. Colleagues, may I greet you all? And it's my absolute pleasure this morning to welcome you to this gathering, which is very exciting, the gathering on mental health at Crossroads. And as much as we're going to be hearing stories only from South Africa and India, it's very much a known fact that mental health in the world, actually, and especially in the low to middle income countries, is one of those areas of health that are completely neglected. Let me also acknowledge colleagues who may not be from South Africa and India, but who are from other countries as well. You are also welcome here. And I hope that the stories that will be shared with you will be applicable to your situations as well. According to the WHO 2022 World Mental Health Report, there were 970 million people living with mental disorders globally in 2019. And this includes 14% of the world's adolescents. Now, South Africa is one of those countries that rank quite low, and I understand India as well. In South Africa, basically, mental health services are very inadequate, and that's the case both in public and the private sector. And of the increasing numbers of people who succumb to mental illnesses, it's estimated that only 27% actually receive treatment. And that treatment, in most cases, is said to be not even adequate. Now, if you look at challenges, they are abound. And they range from individual patient care, community care, health systems level, and also a political level. Now, I won't waste any more time. And I know that colleagues are waiting to share these stories with us, and possibly we can all find some solutions in the common problems that we have among in mental health services. Chairperson, I guess you are the one who's going to introduce the next two speakers. But at this point, I would like to just welcome all of you and say that we look forward to very, very fruitful interactions and exchanges in this regard. Thank you.
Thank you so much, Doctor. Now I would like to introduce our next speaker, which is Dr. Basu. Dr. Basu is our own from the JBI Ekurhuleni. She holds a diploma in obstetrics and had an MSc MED in adverts, and she is a director of Ekurhuleni Clinical Research Center of our JBI. And she is a principal specialist obstetric and gynecologist working as a head of the unit of the obstetric and gynae at the Ekurhuleni district. She is affiliated with South African Medical Research Council Center and the Maternal Fetal Newborn and Child Health Care Strategies. Dr. Basu has presented in various national and international conferences and published many papers in international and national journals. She is an editorial board member of journals and also is a reviewer of various journals. Welcome, Dr. Basu. Let's hear what you can tell us.
Thank you, Chair, and welcome and thank you to everybody. Let me share my presentation first. My presentation will be very short because it's just introducing our new center. Is my presentation visible?
Yes. Do you want to make it as a slideshow?
Yeah, that's what I'm trying.
Okay.
Just trying to get this black line somewhere else. so that I can actually do the, yeah. Is it a slideshow now?
Yes, it is a slideshow. Thank you.
So I will be basically doing a small introduction of our center, which is a very new center. This is a very beautiful logo actually given by our GBI Adelaide, Australia, when they approved our center. So there are 8 JBI centers in African region, which are in Ghana, Ethiopia, Kenya, Cameroon, and South Africa. And South Africa already has another center, but our center is the second one and number 8 in Africa. This is a small map of our Ekurhuleni district, and there is nothing more to say. I'm not going to start talking about epidemiology and demography of our district, but our district, we have about 4 million people, and we have about 95 health facilities and 6 hospitals of different capacities, such as starting from district hospital up to the tertiary level hospital, various primary healthcare clinic, which are very developed type, and community health center, where actually, which are almost like a small hospital, and they do deliver the women there. Our center was established in February 2023, just this year, few months old. We are trying to crawl only. And I'm not going to read each and every words here, which are quite extensively written. Basically, it's a purpose to increase our knowledge, and particularly about the evidence-based healthcare. And our center's focus is mainly on the maternal, fetus, newborn, child, and women's health at the primary level of care. And obviously that will help various other stakeholders. And also we like to exchange the information and knowledge and translate the knowledge for developing the evidence-based guideline, protocol, and so on. And then also to promote, let me see something here, which is kind of, if I can take this black thing up or down. Yeah. So, and to promote professional culture, ethical conduct, particularly because if we practice evidence-based healthcare, then we can practice so. And then also to collaborate and learn from other affiliated center or center for excellence and so on for our effective practice. But the main aim, the principal aim of our center is to practice evidence-based healthcare in the area of maternal, child, and women's health by implementing the evidence into the practice. And obviously that we will be doing scoping reviews, we will be doing systematic review to gather the evidence from our reviews and then try to implement those review recommendation into the practice to improve our healthcare practice in our district and eventually in South Africa. So we work with some very excellent partners who are always assisting us, and we actually have quite a few of them. Our own Ekurhuleni Health District, which is a part of the state government or provincial government. We have another sector in the district, which is called Municipal Health City of Ekurhuleni. We have our excellent, enthusiastic, quite a few core members to start with. Actually, we are quite few members, but members are so enthusiastic that we're really doing quite well as only a 6-month-old baby. And also University of Pretoria's WHO Collaborating Center is assisting us in various aspects. And we have research partner, South African Medical Research Council, and then academic activities and various support we receive from the University of Pretoria. And obviously our international partner or collaborator so far have been MANT JBI Center in India. And although we like to increase probably our collaboration with many other, maybe in future you will see that we hosting a colloquium of 3 countries or 4 countries together. So we have a established governance structure. I won't go into details of that. Basically, our Ekurhuleni District Chief Director, which is the highest position, he is our governing governor actually of our center, and followed by we have a convener and deputy convener, or if you can call director or deputy director. we have quite a few administrators, and of course we have group members, and we also have few associate group member. Because we follow a strict criteria to be the member in the JBI, because we all must be trained for the systematic review, scoping review, and so on. So we allow, because we are just starting, we allow some associate member who are waiting to be trained for those reviews, those review training. Then they also started working with us to have a feel that how the center works, and eventually they will be also the group member. So there is a small draft plan of activity we created when we actually started, because we thought without a deadline and without a proper actually activity plan, we won't actually succeed in this venture. As this to maintain a JBI, there are a lot of hard work and a lot of teamwork involved. So I'm not going to read all these things, but systematic review comes at the top of the priority, scoping review also, and then clinical partner engagement with various clinical like health facilities. And we'll be probably ourselves going for further more training with the JBI Adelaide, and we'll eventually start training other people in our in South Africa to train on the systematic review and others prescribed training by the JBI Adelaide. And then, yeah, those are the main one. And we eventually in future, we hope that we'll get a research grant for having a PhD student in our institute, and so on. So those are few planned, and we have jotted down some year wise, so that we have actually something to look forward and something to look into it. Without a deadline, without a timeline, we can fail. So our 2023 activities, we have kind of planned and jotted down, but we may not have succeeded in all, but we are trying. We do meet our operational group meeting, core group member. We do meet religiously every 2 weeks, we meet. And then we don't want to lose the momentum. And our advisory board meeting is once a month. We have not fulfilled exactly once a month, but we do meet. And as I mentioned, that all our members are actually trained. And then we would like to start training as well other people to help the other people in our district plus in the country. And we already started little bit working on the scoping review and systematic review protocol, as we are still learning. So, but we already started, and we are already collaborating with CPHR-MANT in India, and we already actually hosted jointly a symposium in June, and we're hoping to do the JBI colloquium in 2025, which is much bigger event. And we have clinical partner activities, such as we are hosting every alternate month a JBI Journal Club, which is going very nice, very well. And we will be actually then work with the clinical partner at our hospitals or MOU or clinic, which apparently there is a date to apply with the JBI Adelaide, which we missed the date. So we'll be starting that from the next year. And obviously, I think mentor organization identification, I think CPHR-MANT has got much more experienced mentor, actually, like Prof. Denny John. Actually, we already identified him as a mentor, and we will be slowly probably going to be trained by him, some of our member and so on, and that will also happen. We have created some communication platform. We have an email, we have a website, Facebook, Twitter, everything we have, although not very actively participated, but we did actually develop. And that's all about JBI Ekurhuleni. Thank you very much.
Thank you so much, Dr. Basu. As a young baby in the JBI, you are doing well. So at least you are in a correct stages of development. You are not behind. So it looks like you are doing so good. Well done. Now I'm going to welcome our next speaker from India, Dr. Mukherjee. Apologies if I said your surname wrong. Dr. has been serving as a director at the MANT since 2003. He has been acting as the head of Center for
Dr. Magida, we had communicated that Dr. Mukherjee will not be able to attend, so I am replacing him. The email was sent in the morning.
Also, Dr. Denny will be presenting now.
Yeah,
Okay.
he had
I
urgent
Yeah,
field travel.
Yeah.
Okay, I apologize. That means I've got the wrong program. Okay, Dr. Denny then will be talking on behalf of Dr. Musser. May you please, can you take the stage, Doctor?
Yeah, thank you. 1 minute. Can all of you see my slide?
Yes, we can see your slide very well.
Okay. Yeah, thank you. Yeah, I think my apologies to the participants. Basically, it was communicated only early in the morning. So I'm the co-director for the evidence synthesis and evidence implementation for indigenous health, which is the JBI Affiliate Center. And you notice the logo on the left side on the top. Similar to the JBI in South Africa, we are also just completed 6 months in the month of August. We got the selection in February, and we had an inaugural program in the month of March. So we have a group of people who are, and I'll just give the details of the team in a couple of slides, but we have all of the members have got training on JBI methods, including the comprehensive systematic review training program. However, we also go beyond JBI because I am chair for the Cochrane economic methods, and I'm also part of the disability coordinating group at Campbell. So we also work with Cochrane and Campbell for various systematic reviews. However, our focus is on indigenous health, but in some cases we also go beyond and try to focus on general populations, essentially to understand what is the differences of various health impact. For example, one of the recent reviews that we have started is on zoonotic diseases. And but in some cases we also try to give general populations and try to make it comparable for that evidence with the indigenous population with the general population. So our center was inaugurated on the 11th of March. Our focus is of three main areas. We essentially provide a lot of methodological inputs to a lot of the groups. We have multiple groups in India. We have South Africa, which I think Dr. Jayati has already mentioned. But there are other members in other countries also where we support. And the intention is to collaborate with both clinical and public health practitioners for through evidence synthesis and evidence implementation. And finally, we also aim to provide training and also evidence-based healthcare. We have been invited a couple of places where we give short courses where focusing on scoping review or systematic reviews. And also through those workshops, we end up mentoring those groups for some of the systematic reviews that are currently ongoing. So this is a small team that we have. So I'm the co-director of the center, and the other members in the bottom is Preeta, Dr. Ida, Paramita, Sajda, Bishwajit. All of them are trained on JBI methods and contribute to various systematic reviews and scoping reviews and evidence gap maps. And we have Dr. Vivek Verma, who's an adjunct faculty, and he's a biostatistician. So he provides all the statistical support in terms of meta-analysis or Bayesian methods kind of inputs for our systematic review team. So since we are a methodology team, we also work on multiple varieties of evidence synthesis products, ranging right from systematic reviews, scoping reviews, meta-analysis, network meta-analysis, evidence, economic evidence, evidence and gap map, rapid reviews, and finally using artificial intelligence and machine learning to do living systematic reviews and evidence and gap maps. So these are some of the currently the evidence synthesis that we are in progress. You'll notice some of the topics are very specific to indigenous population. For example, one of the reviews that we are ongoing is on prevalence and risk factors of non-communicable disease in indigenous population. However, because we are also having economic evidence, expertise, some of our reviews are focusing on economic aspects. One of them that you notice would be, which is relevant for countries like South Africa, also is cost effectiveness of decentralized care model for managing MDR-TB. glaucoma screening. We also have CPHR-MANT has been focusing on tobacco control as a research area. So some of our focus areas are on tobacco control. And also we pick up, lately we have also identified climate change and zoonotic diseases as one of the focus areas. So these are some of the ongoing systematic reviews that are currently in progress. And this year, I think somewhere around June, we managed to get a collaboration as a clinical engagement partner. So the Faculty of Dental Sciences at Ramaya University of Applied Sciences we kind of applied for it and then we got it. And so currently we are mentoring 2 evidence implementation projects, one focusing on tobacco cessation and prevention in dental setting. And the second one is focused more on school oral health program for improving oral health in school children. So these are evidence implementation where it's focused on how to integrate evidence synthesis with implementation, and the intention is to bring out some best practice evidence-based implementation projects. So these are some of the activities that is currently ongoing. Our team got trained in 2002 and the application took some time. So we did not wait for the JBI affiliation to be awarded to us. So that is why we have used the 2022 onwards. So some of our teams have already started to work on protocols and reviews. Some of the reviews that are published already, most of them are currently at the protocol stage, but we are also started to move beyond and complete. So we had recently, for example, late of December, we had a scoping review of the methodological quality of research on mental health of healthcare professionals in low and lower middle income that was accepted. So yeah, that's it from my side. Thank you.
Wow, congratulations, Prof. You guys, you are doing well in India. We definitely need to collaborate with you so that we can be at your stage soon. But I know we at Ekurhuleni, we're also doing well. We're gonna be there soon. The next session is gonna be shared by Prof. Denny Hugo. Prof is a family physician. He is currently working as a director of the University of Pretoria Community-Oriented Primary Care. He is leading the academic development and implementation of community-oriented primary healthcare, including mobile data system and the implementation of a community-oriented substance use program, which is called COSAP, in collaboration with the city of Tshwane and Gauteng Department of Health, South Africa. Prof. Hugo, this is your stage.
Good morning, everybody. Can you hear me?
Very well, Prof.
Okay, thank you. If I take the message that came from the previous, from Dr. Denny, I'm probably the only chairperson for this session because my partner is not here. Am I right?
He has an urgent field visit, so he had to go, and he sent the apologies in the morning.
Okay, no, that's fine. I just don't want to take over if he's here, but it's good. Thank you very much. Many advances that we make in our careers is to start somewhere and then to move. And I see this seminar as the start of a long-term collaboration and partnership. I've been in India earlier this year, and I came back with the view that there are numerous reasons for academic collaboration between India and South Africa. Partly because we have similar type context of huge differences in the way things are with people, and also we have both grown under the colonial system of the British. And whether we like it or not, we learned a lot of that in our culture. So we understand each other. And I also appreciate that we have respect for each other as collaborators. So I'm looking forward to more and more South African and Indian collaborations. This session is about community mental health in India, and then also a presentation of mental health in South Africa. So Dr. Chitra Venkateswaran will do the first presentation on community mental health in India, and she has a long CV. Let me just find that. Important is that she's a clinician. She sees patients. She's a mentor in psychiatry and palliative care, and involved in international and national positions. And she is currently a Bernard Lawrence Scholar from the Harvard University. Over to you, Dr. Chitra. Thank you.
Thank you so much. Can you hear me?
Yes.
Can you hear me? Yeah, okay. Can you please enable me for sharing the presentation?
Yes, ma'am, you can share the presentation.
No, but I'm disabled.
Okay, we'll just check.
Yeah. Meanwhile, thank you for the webinar month, and I've been working with Dr. Denny John for a while now, and a few other persons who are going to speak today. Basically, I'm a clinician, I'm a psychiatrist, and I work in the community. Both as I work in a medical school in Kerala, as well as I run a community-based mental health service. So I'll just be speaking, giving you a brief overview on the community mental health scene in India. I hope you can see the slides. Can I start? So I'll be just giving you a historical perspective, and also get on with what's the scene now, and what are the challenges, and what could be some solutions that we see, because we work on the ground. So just to give you a brief introduction to this topic regarding India, because many of the audience is from South Africa and other places in the world. An estimated 97.3 million people have mental disorders in India. That's the recent evidence. And there's a huge treatment gap, like more than 80%, like 83 to 89%. But the annual health expenditure of India is only around 1.15% of the gross GDP, and the mental health budget is less than 1% of India's total health budget. We have a national mental health program which was launched in 1982, so several years back, but still we are struggling, and there's only a partial achievement of the mental health outcomes which had been outlined in the national mental health program. And there's a very slow progress in integration with primary health services and community-based services, though there have been several attempts and several strategies in terms of how to reach the most vulnerable people. It has been a very slow process, but I'm just giving you how community psychiatry is in India in terms of what is domain critical care at all. I mean, at the primary care level, it has a robust referral system to an extent in urban kind of, or in some states, I would say, which has an existing good health system already in place. In rural areas, it's very tough to have a robust referral system as well as continuity of care. There is a rehabilitative aspect which is mentioned. Resources kind of poor in India, though there is a lot of work being done in terms of training the primary healthcare service medical professionals. There's a lot of work, community psychiatry, the the people who work in community psychiatry do in terms of promotion. A bit of research happening also, and a lot of networking is necessary for intersectoral, to reach that coordination and to recommend for policies and fund location. I'll just briefly go through how the models have developed in India in terms of, especially for the community mental health model. There was the first asylum, as in reports in 1745 in Bombay, which is in, the western part of India, which is now called Mumbai. But a clinical, the community service first started in Calcutta in 1933, followed by Bombay again, now Mumbai and Patna. The development of community mental health in India did not come only focusing on the human rights aspect as in Western world, but more out of an inadequate hospital-based services, and also to focus on the role of family as carers for an illness. In the 1950s, we see a change in terms of looking at mental health services in the community, where first there was establishment of general hospital units, and we had several people who took the initiatives to start some model of community mental health service, like Dr. Vidya Sagar in Amritsar started providing family members accommodation in tents to stay with patients in hospital premises. All India Institute of Medical Science in New Delhi in 1964 started the Comprehensive Rural Health Service Project. In 1970, saw WHO funding a project in Haryana under PGI, the Postgraduate Institute of Medical Science and Research in Chandigarh, and NIMHANS, which is a premier mental health training and clinical center in Bangalore, began services in Sakalvada again in the 1970s, which is in Bangalore in South India. Then all these community services actually propelled or laid the foundation to develop or establish the National Mental Health Program, the NMHP, which was in 1982, like I said earlier. It has three objectives generally: to improve the availability and accessibility of basic mental health care for all, to apply the mental health knowledge in general healthcare, because we are looking at primary healthcare. So it was to integrate from that, from 1982, there has been an emphasis that it has to kind of integrate or apply the medical practitioners should apply the mental health knowledge in general healthcare and in social development, and also to focus on promotion of community participation. The important achievement of National Mental Health Program was establishing district-based models. That is when you have each district. So India has a number of states, and then these states have a number of districts. So each district would have a basic service, which is called the District Mental Health Program, which will work in satellite primary health centers. And this was started again by NIMHANS in Karnataka in Bellary district. So this was the prototype of the first community health center, mental health service, which was started by the Government of India. And this is called the District Mental Health Program, which is still running. And it's the core of the mental health services at the governmental level, and started in 1996. What happens in this is the primary healthcare centers, the existing staff is trained because there is inadequate resources anyway. There is limited number of mental health professionals, where it be psychiatrists, psychologists, or social workers. So, and also to use the existing staff effectively, they are being trained. But that also has disadvantages, which I'll speak about earlier. Evidence up till 2021 says that DMHP has been implemented in 692 districts out of 718 districts in India. That is what the reports say. But some states, especially in southern India, like Kerala, where I work, in Tamil Nadu, certain districts in North India do very well in terms of DMHP, but in many rural areas, still it is in basic coverage is not really attained. And DMHP actually focuses on service provision. There is an outreach component, and it also includes school mental health training, life skills education at schools. Suicide prevention is one of the main goals, and also addressing vulnerable populations, those with chronic illnesses, single women, elderly. So there's a lot, and children. So the vulnerable populations are also addressed. DMHP also focuses on sensitization and training, and there's a lot of awareness camps, and community participation is given emphasis. But there are still challenges existing in spite of the progress that has been made in the almost 2 decades that we have seen. There is inadequate staff resources. People do not choose to join a district mental health program, the program as or the community mental health services because of the budget allocated. people psychiatric practice in the private sector is lucrative, or people leave India and go to either United Kingdom, USA, or Australia, and they have a good career, as well as they have, they make money too. So it's the kind of a challenge to have budget for paying the mental health professionals. There is also inefficient administration. Some states fare better because of existing robust health system, like I mentioned, but otherwise the coordination is almost like an uncoordinated, fragmented approach and very ad hoc in terms of, how it functions is quite, the planning is all sometimes very ad hoc. There's definitely a lack of indicators, so there is only poor evidence. There's only few evaluations that has been carried out, and the program is still implemented on older guidelines, even though new recommendations have been given, and there's scant research. It is actually a vertical program. It is not something which goes laterally into the community or includes the users, the carers, and the community. But it is also seen that one size doesn't fit all the states, because India is quite a large country, and so on the other side, we see that with the single kind of program, there is a non-uniform adaptation, because culturally we are very different. The states are very different in terms of language, in terms of culture, in terms of the resources that we have, and so it is impossible to actually have a uniform adaptation as well. So let me talk briefly about the governmental policies and legislation. Like I said, the National Mental Health Policy, or the Mental Health Program, came in 1982, and the policy was revised in 2014, making it more inclusive, participatory, and also focusing on the rights and evidence-based approach. Definitely looking into the non-medical and medical aspects as well, because there is a tendency otherwise that the clinicians actually take a larger role in terms of decision, but there is now a focus of making it multidisciplinary and having the non-medical aspects as well. So we have a Mental Health Care Act, which came up in 1987, which is now superseded by a new act, which came up in 2017. It is progressive and it's rights-based, but it is criticized for poor focus on continuity of care in the community and cultural sensitivity. There are other governmental legislative or acts also which help people with mental illness, like the Rights of Persons with Disabilities Act, which came in 2016, which actually focuses on inclusion, non-discrimination, accessibility, equal opportunity, especially primary needs of housing, shelter, income generation, etc. Other than the governmental programs and the private sector, in the community, one of the major players is the non-profit or non-governmental model, and they have a very strong role in India, in almost the whole of India. I also belong to one non-profit organization other than the medical school I work in. There are some common methods of approach that these non-profit organizations adopt. That is like training. They focus on training of community volunteers for identifying, screening, and simple techniques of supporting the people with mental illness and their families. Help, the non-governmental models help in establishing mental health clinics in the catchment area, increasing awareness. They also look into use of local resources for rehabilitation, empowering the family members, trying to sustain the model that they work, and they also network with other medical and organizations, which is crucial for resource mobilization for community-based programs. I'm just going to now speak about some specific important programs that are happening in India. One is the SCARF, many people would have heard about it, Schizophrenia Research Foundation in Chennai in South India, and Sangat, which is also a very reputed organization in Goa, which has developed community intervention models for psychiatric disorders. The community-based rehabilitation in urban rural areas, the psychiatric service model, STEPS, developed by SCARF, is quite known. Similarly, Sangat has a MANT program for depression, DIL protocol for geriatric depression, then COPSI and Sundar for mental health for all. There are many organizations which work in the field of suicide prevention, like Sneha in Chennai, Helping Hand in Bangalore, Sanjeevani in many more, which I could not get details about. There is a group called the Center for Mental Health Law and Policy, which focuses on making data and information on mental health related to law, policy, and programs accessible. So they're doing really innovative research projects in terms of all these areas. There is also a lot of research coming up for these models. They're using the WHO QR toolkit in Gujarat and the WHO MH gap framework for training mental health professionals for awareness generation has seen to improve the quality and the human rights condition of people accessing healthcare services. This has also been seen to reduce the treatment gap in half the reach areas in Jammu and Kashmir, which is the northernmost state of India. There is an example of a combination of, the indigenous kind of treatment, like the magical religious treatment, and the modern psychiatric interventions for the treatment of mental illness. It's called the Dawa Dua project. So Dawa is medicines and Dua is prayers. So that is a combination, and it is very important that because we have a multicultural kind of, aspects in our society, we cannot avoid the, alternative or the complementary kind of approaches, and we have to work in together with them. And this Dawa Dua project actually provides mental health treatment for those who visit a dargah, where people come to pray actually, and then the medical treatment is also combined. There are non-specialist care programs which are found to be effective. That is, there is a low-cost skill transfer, which helps the models become more feasible, acceptable, and cost-effective. The George Institute of Global Health has a smart mental health program, which is a digital mental health application for screening, management, referral, and treatment. And this has shown positive treatment outcomes in Andhra Pradesh, which is another state in South India. And telepsychiatry and mobile telepsychiatry, especially this became very, very significant during the COVID-19 pandemic for reaching out to vulnerable communities. NIMHANS in Bangalore takes an important role in terms of advocacy and having a model for telepsychiatry. Their ECHO model is quite known for this. But in spite of all this, we have challenges on the field. There is lower priority in terms of funding in comparison with other physical illnesses like cancer and other illnesses. The stigma across all the levels of governance as well as in the community, also in terms of even the medical fraternity. There's no focus in establishing sustainable health systems. Like I mentioned earlier, for example, the medical officers in primary health centers generally hold the position for 6 months to 1 year, and hence recurrent training of newly recruited officers becomes necessary, which leads to poor competencies and poor continuity of care. There's limited public health perspectives in mental health leadership. There's a lack of consumer movement. The vertical nurture of the community health programs, with different programs competing for the health workers' time and expertise. So it is the same group which is trained for many programs, not only for mental health. Whenever an illness comes, like, we have a lot of infectious diseases which happens during the season. So the same health worker, the same community health worker is pushed for time and expertise, to focus on all this. There's also the lack of trust leading to poor collaborative or partnerships in provision of care and other tasks. This comes from my own experience, because when a non-profit person goes into the community, there is a lack of, especially in some states like Kerala, there's a lot of suspicion into what we plan to do and how to trust and how to establish partnerships with the governmental agencies. What could be done? These are some of the, some points that I've brought about from evidence as well as, for my own experience. Like, we should have task shifting courses so that non-specialist cadre can be improved. So there should be skill-based courses in terms of mental health. There should be focus on community-based care. There should be, it should be given priority in psychiatry and medical training. There should be strengthening of the general health infrastructure so that this can be added on. There's a need of political will, which sadly, so fluctuating. And there should be the bridging of mental health issues with existing public health priorities, with research being a priority. I believe that collaborative care is probably the way forward. Not a single agency cannot fill the gap. I think we should all work together, whether it be NGOs, private health systems, traditional health systems, state healers, other NGOs, governmental agencies. Everybody should pitch together, work together with trust, and then fill the gap. There should be decentralization of the resources. Communities should be given the ownership. The government should be ready to give the community ownership to lead the program. There should be continuous support for primary healthcare workers. There should be support from the stakeholders in the community, media especially. There should be champions from the community lead the cause. And we should incorporate technology-based methods like telemedicine to improve access even in the rural areas. So I just want to summarize these 2 points, which I believe are the way forward. One is that the public health measures with primary health services would be the most sustainable and effective model given the limited resources in a country like India. And collaborative care model with partnerships to address treatment gaps should be promoted. Thank you, and these are the references.
Thank you very much, Dr. Chitra, for a very comprehensive presentation. it reminds me of what we have said many a times before, is that the practice of healthcare has more impact on policy than policy has on practice. And you have clearly laid out in your two last slides how we can improve that and build collaboration. So my challenge would be to all of us is find a place where we can implement those things, and that may then be seen in policy after time. But I think I'm sure there are questions. I just for the sake of time would first give the next speaker a chance to talk so that we have time for discussion. Is that fine with you, Dr. Chitra? You will stay with us.
No. Yeah.
Okay.
No problem.
Thank you.
Yeah.
Thank you very much. According to my program, there's Dr. Naiker will make the next presentation. Am I right? Is Dr. Naiker around?
Yes.
Can I? Okay. Unfortunately, I don't have a bio. So could I ask Dr. Naiker, please make yourself visible and introduce yourself and your career to us. Thank you very much. Go ahead.
Okay, thank you. I tried to make my video available, but it seems like it's not showing. But if I could share my screen to begin.
Okay. Do you have a presentation that you will share, Dr. Naiker?
Yes.
Okay, then we'll settle for the second best and see your presentation. Please go ahead. Thank you.
Thank you. So I am
While she's showing, I see it's my neighbor and colleague from Steve Biko Academic Hospital. So at least we know that she is working in the best academic hospital in South Africa. So Dr. Naiker, go ahead.
So I should also agree with you there. Otherwise I wouldn't be here. So I'm Dr. Naiker. I'm a specialist psychiatrist jointly appointed at Steve Biko Academic Hospital and University of Pretoria. I've done my postgrad registrar training here since 2018 and started as a specialist psychiatrist earlier this year. And I'm also involved in academia. So just to the contents of the presentation will be an overview of mental health in South Africa, determinants of mental health, the challenges, the progress and proposed solutions, and a conclusion. So please excuse me. I also have a bit of a flu. So in 2022, the population of South Africa was estimated to be 60.6 million, with children and youth comprising of nearly 38 million of that. 1 in 3 South Africans suffer from mental illness, with 2/3 of them unable to access treatment. Approximately 16% of South Africans experienced a mental or substance use disorder in the previous 12 months, with 2% assessed to be having a severe mental disorder. Others were diagnosed as having a common mental disorder, which included depression, anxiety, and substance use disorders. Mental State of the World Report 2022 in South Africa ranked South Africa the lowest in terms of mental well-being. The percentage of population distressed or struggling with their mental health was at 35.8%. More than half of South African adults have been exposed to adverse child events, and about 40% of them have experienced some form of emotional neglect before the age of 18. So a 2022 national survey found the prevalence of probable depression in South Africa at about 25.7%, with the highest amongst women, those who are widowed, divorced, or separated, and those who are retired or above the age of 65. The South African Federation of Mental Health and SASOP also found that the third highest rate of suicide was in South Africa, and it also ranked 10th on a list of countries with a 23.5 per 100,000 population. There's also a severe problem and a shortage of services of child and adolescent psychiatry, and there's a paucity of studies available in our context. There's no national data available, but one of the provinces in our country reported the prevalence of child and adolescent mental disorders to be 17%. A systematic review that was also conducted across 37 studies published between 2008 and 2020 showed that the magnitude of mental disorders and mental health symptoms amongst adolescents in the general population and living in sub-Saharan Africa to have a median point prevalence of 26.9% for depression, 29.8% for anxiety disorders, 40.8% for emotional and behavioral problems, 21.5% for the one PTSD study included, and 20.8% for suicidal ideation. So just in terms of determinants of mental health, it's a complex interplay of individual, family, community, and structural factors that can change over time and that are specific to individuals. So it's very individualized. And as you can see from this figure, individual vulnerability is then directly proportionate to the stresses that one experiences. So the higher the stress, the higher the risk of mental conditions. And in this slide, I included this nice sort of risk and protective factors that determine mental health, because there's lots of factors that influences one developing mental health. So I won't go through all of them, but just to mention on the slide, majority of government expenditure is spent on key social determinants that also impact mental health, such as poverty, unemployment, housing, education, social security, safety, and nutrition. However, they're not considered when the budget is allocated to mental health to target these specific determinants and allocating a higher budget to mental health. So just in terms of challenges, I'll speak a bit more about these, but we have resource challenges in terms of budgets, human resources, the availability of medication at district levels or primary healthcare levels, as well as some tertiary hospitals. Sometimes we run short of common medication, even that of risperidone. So the burden of disease estimated cost to the economy was 3.6 billion US dollars in South Africa. There's also high substance misuse in our country. In terms of alcohol, we were top 20 worldwide with the highest prevalence for fetal alcohol syndrome, with 29 to 290 per 1,000 live births. And then our child and adolescent services infrastructure is really poor. We have an increasing demand for these services. However, the general practitioners that people find at clinics or district health levels are unable to manage such complex psychiatric patients, and then they sort of don't then seek help and get the wrong help. So we need more infrastructure and to also train more child psychiatrists. So in terms of policy implementation, I'll come to that. And as mentioned earlier, I think stigma is worldwide, and it's a huge problem in our country as well. We also adopt a biopsychosocial cultural approach, and most of the time it's working and educating the families about mental illness and collaborating to then alleviate stigma surrounding individual stigma, community stigma, the family stigma as well as that of healthcare practitioners. So just in terms of the resources available in terms of professionals, as you can see here, psychiatrists are only 0.31 per 100,000 of uninsured population. So this is the public sector, which is the majority of our healthcare users. And then you can also see registrars who are training, it's 0.01 per 100,000. Psychologists are also less than 1 per 100,000 uninsured. And there's some other specialities also mentioned. So we have a large public health system that serves about 84% of the population and a smaller private sector to serve the affluent minority. 40% of the overall health budget is funded by the state or the public sector, and mental health services only forms 5% of that health budget. And there was also a recent health budget cuts across the board. So you can imagine that we got less of the budget. In 2016-2017 financial year, mental health costs in inpatient and outpatient services amounted to 573.6 million USD. 86% of overall expenditure was on inpatient care, with only 14% towards outpatient care. And of that, specialized psychiatric hospitals used up 45% of that budget, with primary healthcare systems only using 7.9. We also have huge discrepancies between certain cities and provinces, as some are more developed than others, and people then tend to want to be in the well-developed areas. So the progress that we've made in terms of this, we have the Declaration of Alma-Ata of 1978, which then focused attention on primary health care in order to achieve an acceptable level of care for everyone worldwide. So in our country, we also had an apartheid system where there was huge discrepancies between the different races that constitute our country. And prior to 1994, mental health care was highly institutionalized, racialized. The rights of individuals were secondary to the rights of society. If someone had a mental illness, they were removed from their communities and they were institutionalized. And once they were institutionalized, there was no hope of appeal or recourse from the law. But this changed in 1994 when our country took a more democratic stand, and we had numerous policies that were then developed, which then also protected the rights of all of our citizens. And there's numerous ones, I mentioned a few here. The Mental Health Care Act was also then reviewed, and we now follow the Mental Health Care Act 2002, number 17 of 2002, which focused on human rights, decentralization and integration of mental health care at all levels, focus on care, treatment, and rehabilitation of our mental health care users. The Mental Health and Poverty Project of 2005 and 2010 also was an important aid in drafting mental health policy frameworks, which are currently in process, as the project spanned over 5 years and looked at 4 African countries with the hope to build an evidence-based policy level intervention. And then we also adopted the National Health Insurance Policy, which is still in its frameworks and to be implemented. And this promotes equity in health service delivery towards universal health coverage, which will also have its own challenges when implemented. So in terms of solutions, there's individual solutions. So I think it's important to always include your mental health care users in your treatment plans, your management, collaborative efforts in coming up with solutions, make them feel included, psychoeducate them, make them ambassadors and advocates for mental health in order to try to alleviate stigma, foster a sense of purpose and participation of them in the community, we're developing inclusive programs to integrate them more into society, because I think that's something that really lacks in our environment. On the community and family front, I think support should be given to NGOs that support community-based mental health care programs and initiatives, mental health education across all boards, be it schools, work-based education, healthcare practitioners, community level education programs. And then also, it would be great if we could have the capacity to have mental health teams in the community that could visit patients, especially those who live far from healthcare facilities, or those that don't follow up, or those that are high risk to relapse, in order to prevent those readmission and relapse rates. So structural collaborations, as mentioned before, intersectoral collaboration is very important. Stakeholders and personnel from all levels of healthcare should collaborate together to come up with plans that could be implemented. The availability of medication at all levels of care, so patients don't have to travel far distances to get tertiary level care medication. Periodic evaluations of mental health services and implementation of policies is also very important, with prioritizing research, especially in areas like our child and mental health services. Currently in Gauteng, there's collaboration between the entire district and stakeholders to try to come up with a functional child and mental health service. And it's important to also move from a hospice-centric care to a primary health care unit, because as you saw, most of our expenditure is for inpatients, and then the primary health care facilities are not well supported. So if we could have more infrastructure there, it would obviously lessen our inpatient burden. Task shifting of services to non-specialists who get ongoing supervision and training, and also mental health promotion and prevention. We can also try to give early access to mental health care users, and that leads to early diagnosis and treatment. So here I found quite an interesting account of a mental health care user's journey. And he's actually a South African Federation of Mental Health project leader. So he was always referred to as a black sheep of the family, dismissed as crazy, pretending to be sick. He didn't know where to get help. His family was not supportive. They said, be strong, get over yourself. This is a white man's disease. Black people don't have such things. And the family stigmatized him. And that also led to delay in accessing healthcare. And he deteriorated and became violent and aggressive, and eventually then admitted. He stated he was never informed of his diagnosis and his management thereof, how to deal with his mental illness. And he was admitted for 4 years because his family didn't want him back home. Then became estranged from family and moved around a lot to try to find a place to stay when he was discharged. And eventually he mended bridges and is close to his sister and his mom, which is great. And he actually turned his story into something good, because his experience then prompted him to volunteer and start creating awareness on mental health. So if we can do something like this with our mental health care users and give them the psychoeducation and the tools that they need to be advocates, instead of be stigmatized around their illness, it will also help health-seeking behavior and our state of affairs in our country. So I also found this table quite nice in terms of the intrinsic and instrumental value that is displayed here. So when we are mentally well, we can connect, function, cope, and thrive. When these needs are not met, we become unwell. So like with the story that I just displayed, highlights the complexity of our current mental health care systems. And although we might have made progress in terms of policy and legislature, have a very long journey ahead of us. Determinants of mental health play a pivotal role and should be approached in a holistic manner in order to improve mental health. In order to implement all the proposed strategies and legislature that has been laid down, appropriate budgets and plans need to be in place. Until they aren't, those won't come to life. Mental health needs to be prioritized. However, we continue to be advocates and do our utmost best for our patients and their families with hope for a better future. Those are some of my references. Thank you.
Thank you very much, Dr. Naiker. Apologies for the sound effects towards the end. Colleagues, we have 5 minutes for questions. And I have said that the people should put their question on the chat. There's one from Dr. Ida du Plessis-Fourie. Could you pose your question, Dr. Ida?
Good morning, everyone. I'm not sure if I must put my camera on. As long as you can hear me, then that is good. Can you hear me? Can I get confirmation? Okay, perfect. Thank you so much. Thank you. So just in short, I am a registered nurse and midwife. I've done my research and PhD, and very thankful to be part of this meeting. I'm in Dr. Basu's team. So the question to the last speaker, I posed the question of, it's actually rather making you aware from a nurse perspective that, are you aware that in South Africa, the nursing curriculum has changed towards mental health? That's one of the big changes that took place. So mental health used to be integrated in the 4-year degree that we did as a subject. And I can't remember the exact period, the number of hours, learning hours that it was provided, but it was a subject on its own. Students had to spend many hours in the clinical area. And then the Nursing Council, which is the nurses' governing body in South Africa, have instructed recurriculation of the nursing degree. And one of the significant changes that took place was that we used to call mental health, it used to be called psychiatric health or psychiatric nursing. Now it is referred to as mental health in the new nursing degree, but only a few hours, as a fraction of the amount of learning material and learning outcomes that the students had to reach is now made available, which is a very big concern. And especially if you listen to the statistics that was just shared by Denali, and it sounded like you are on the medical side, and this is why I'm standing up and putting my hand up as a nurse, because in the community health facilities, primary health care, we are the ones who see the patients first. I'm more in mother and child world, and yes, mothers and the mental health, exactly like it was stated, and the cultural thing of you can't declare it, or you just lift your head and be fine. And those mothers go back to the clinics hiding their postnatal depression or their anxiety or their insecurity and just emotional, hormonal, experience that they have. So what I'm asking is, as a nurse, and so I also want to challenge everyone, that we need help as nurses to have more training in mental health in our course that is approved by our governing body. We want someone to help us, or a group to help us, because we are motivating for more mental health training. The amount of mental health training that's currently in the course is not enough. Yet it is something extremely important, because to me, it starts in the community health clinics, like I said, and the first phase is the nurses. They need to be empowered with knowledge and skill to identify these patients and, of course, refer them soon and at the right time. Thank you.
Thank you very much, Dr. Ida. I think it's a very important theme, this of specialism versus generalism, and that mental health to be present in both. Let me give a chance to each of the speakers to give a short response on this. Maybe we can start with Chitra. Do you want to respond to this? And then Denali?
This question on inclusion of mental health in the curriculum.
Yes, yes, and the
Yeah.
issue of generalists also knowing enough about mental health.
Important. I mean, it's a very in India, the nurses do. I think in India, the nurses actually train better than the medical doctors in mental health. They have a good component of mental health in the curriculum, as well as they're given postings, the long postings, and there is postgraduate courses on mental health as well for masters in nursing. So you get specialists, especially for academic, teaching purposes. So, and when we are the hospitals, we get nursing students regularly as a rotation to the wards for, observation and learning. So I think it's very important that nurses take a role. And when I said that, when we should have nurse specialists who take lead, especially if it's a community service, we have teams where the nurses or the social workers take lead and see the patient, and we can help them, supervise them, and they kind of plan the care for the person with mental illness and their family. So I think it's very important. Similarly, the generalists, whom we would call, the general practitioners, medical practitioners in India, that's what the government is trying to do in primary healthcare. The generalists are trained. There is a module for training generalists and give them competence in terms of providing basic mental health care. But it is not, it's only a slow progress that has been made in India. It is not superb. In the state that I live in some districts, it's quite good. People do have a basic sense of looking at, mental illnesses and managing them. But it is not superb. It's not excellent yet. Thank you.
Thank you. Thank you, Chitra. I think, Dr. Ina, you can see that if we, for example, open a discussion between the two countries, nursing leaders, perhaps we can start to make an impact. Denali, do you just want to have a short response to that question?
So I think it's a very important point that's raised, especially in terms of the policy framework, moving from hospice-centric to primary health care. The nurses are basically the forefront of our primary healthcare system. And if they don't have the proper training that they require and they're not confident to treat mental health care users, then they won't give them the treatment and the care that they need. And in turn, it can cause anxiety in those staff and all of these other problems. So I wasn't aware that it was removed, because we still have nursing students that rotate through our wards who learn from our MDTs and our ward rounds. And if they ask for teaching, we provide that to them as well. But I think it's something that should be taken further.
Yeah, Thank you very much. I'm sure these things will be taken up after this mini conference. It is now time for tea time. Let's all be back for the next session at 11:30 South African time and 1500 hours Indian time. Thank you very much, and thanks to the speakers and the response. Tea time. Thank you.
Hello. Yeah, what's up, Defender?
Yes, good morning.
Good afternoon. Shall we start the next session?
Yes.
Can we start?
Yes.
Okay. I would invite the other chairperson, Dr. Maruganya from South Africa. Dr. Maruganya, is she around?
Yes.
So we are,
good morning, good
start?
afternoon.
Good afternoon.
Yes, we can start.
Can we,
yes. We can.
Yeah, can we start the second session? I'll just, the first session is, are we speaking on evidence on mental health? I'm not sure about it. Do you want to speak about it, Doctor?
Yes, I think we got about 7 speakers from various institutions and from both from South Africa and India. So I think as Dr. Magida was ready, if I'm pronouncing it properly, so she can start. But basically, we're looking to find out what is the latest evidence on mental health. I think when I going through the past presentations, we saw that there is some data, but not national and not current. And that is always the problem that we have with the mental health. And the bigger problem is that when you now have to ask government to change policy or to, if you want a direct policy, they're always looking for research. So we're hoping that the next 7 speakers will give us some sort of evidence, the latest evidence on mental health, so that when we speak to the local or national health authorities, we'll be able to go there with some sort of research statistics that we can influence policy. Thank you.
There would be one speaker, the last speaker is the voice from the field, probably a community volunteer from Kerala or a social worker. They are out in the community, so we will have one person speak. That will be more of an experience that comes, and there will be a case study from our organization, the Mehak case study by Dr. Purnima. Other than that, shall we just get moving, because I think this is one of the most important aspects of what we are going to discuss today, because if we have to influence the policies, if we have to make changes in mental health scene, evidence is very important, research is important, and that's what JBI and MANT, CPHR just also the partnerships for clinicians like us, partnerships with such organizations makes great meaning. We have a speaker from the Indian Council of Medical Research as well, Dr. Geeta Menon. So shall we start? I think a bit early. Can we start? Dr. Denny, are you ready?
I'm ready.
All right. So I'll introduce, I think Dr. Denny has introduced himself when we kind of spoke. I don't have the biographies. I had asked. Can you share, Dr. Paramita? I don't have the biography.
Yes, I can share.
Or I'll just, let me look into the email. I don't have. A minute.
Should I introduce Dr. Denny?
Yeah. Can you please introduce the speakers, because I don't have their biography.
Yes, sure. Professor Denny John is a research methodologist at the Center for Public Health Research, MANT, Kolkata. And he is also the co-director at the Evidence Synthesis and Implementation for Indigenous Health, a JBI affiliate center. And he is the chair of Campbell and Cochrane Economic Methods Group, as he already told in the previous session, and president-elect, International Society for Pharmaconomics and Outcomes Research, India chapter. Additionally, he serves as the advisory group member for the Disability Coordinating Group, Campbell Collaboration, and member of JBI Grade Adelaide, and member Society for Research Synthesis Methods. He is on the editorial board of Systematic Reviews, Cost Effectiveness and Resource Allocation, and BMC Public Health Journals. In 2019, he won the Global Peer Review Award for being among the top 1% of reviewers by Clarivate Web of Science. He is listed as the top 2% most cited author in public health as per Stanford 2022 list, and he has published over 30 evidence synthesis publications. So that's the introduction of Professor Denny John.
Yeah, thank you. I hope my presentation is visible to everybody.
Yes, sir, it's visible.
Yeah, yeah.
Thank you. So I'll be talking about a little bit, I think a bit of economics was touched in one of the previous presentations. So I'm going to speak more on global, but also some of the research where Dr. Chitra and myself were engaged in understanding cost of mental illness. And currently there's an ongoing study that I'm looking at on understanding what is the cost of, what is the mental health. We are looking at the cost of depression and anxiety in India using a national representative study. So as a part of the introduction, I think just to give a global, because the session is around the evidence part. So globally, mental illness costs billions of dollars, especially in high-income countries related to welfare payments, but also lost taxes. However, there is also, evidence that psychological therapy can not only boost employment and output, but additionally, it has got gains which far exceed the cost of the treatment. In fact, psychological therapy is actually a bargain, which means that for every $1 spent, roughly $1 is saved on welfare benefits, another $1 is saved on physical health care. So you actually have double the returns of investment if psychological therapy is included as part of the health system for managing mental health issues. However, there are also some impacts as well. For example, psychological treatment can actually reduce a person's annual physical health care cost by almost 20%. So those are other benefits. And then you also have that country GDP. We also know that the productivity of a country, which is measured by GDP, needs people with stable mental health requirements. So if the countries are able to cure all depression and all anxiety, it can actually boost the GDP by around 4%. However, in most countries, a very tiny majority of people with depression or anxiety actually receive any kind of evidence-based psychological therapy, with nearly 1 in 5 adults worldwide with a diagnosable mental illness. And people with mental problems are also physically ill, typically use 60% more of physical health care equally ill people with mental illness. And finally, if you use a kind of a national income criteria, the extra physical care that people with mental illness almost cost 1% of the total income, which means that essentially you have people who have mental illness, then you need also caregivers. So if you take their productivity loss also into consideration, it's a huge impact on the economy. So what I wanted to mention in this slide is not only that there are benefits, but at the same time, there are some challenges in terms of it impacting not only at the individual level in terms of higher costs, but also in terms of the impact at the national level in terms of GDP and lost taxes. So if you take India in particular, that's what I'm trying to, because I'm based in India, so most of my research is focused on India. If you take India in particular, the WHO estimations in mentions around 2,443 disability-adjusted life years per 100,000 as a burden of mental health problems in India, with an age-adjusted suicide rate of around 21.1 per 100,000. So if you take just India in particular, it is estimated that from 2012 to 2030, it's expected that the economic loss due to mental health conditions in India would be an estimated $1.03 trillion. And this is going to be, I think when these numbers came, we were not talking about COVID as because these are estimates from 2011, 2012. So if you take COVID into consideration, these numbers are not going to hold true. In fact, the numbers of amounts of 1.03 trillion can go up as much as double the amount that is mentioned here. This is from a paper that Geeta, who's another speaker, then Chitra, me, we're all engaged with. We actually used a national database of a large national representative survey. Our intention was to understand, and this database had reports, people reporting mental illness. Our intention was to understand what is the cost on mental illness. So from there, we found that almost, an average of 2,150, which is roughly around, if I can say, $35 per month is spent by a household if a member has mental illness. And this actually additional expenditure adds up to 18.1% of the household's monthly expenditure. Our analysis also showed that the average cost of hospitalization for both psychiatric and neurological ailments was actually comparable to those associated with cardiovascular ailments. And typically we use cardiovascular as a reference because that being a chronic disease, but also requires high expenditure, and also cardiovascular being affected to a majority of the population, that also is the reason why we compare that. So if you take the extent of catastrophic health expenditure is a measurement where we try to assess that if a household has spent on health, how much are they getting affected in terms of the expenditure being catastrophic. And typically we take 10% or 20% thresholds of the overall household income. So if you take those two thresholds, our analysis actually showed that almost 59.5% at 10% threshold and 32.5% at 20% threshold were actually exposed to catastrophic health expenditure. And because of this catastrophic health expenditure and this additional, the high expenditure that they have to spend, our analysis actually showed that 20.7% of the household are actually forced to become poor from being non-poor before being treated for mental illness conditions, just because they spent money on managing mental illness. And the graph on the right side is trying to show the state-based estimates. And you'll see while the India average is around 2,115 rupees, pardon, these are all in rupees, so I couldn't, because it was published in a journal which accepted India as the rupees as a currency. So I do not have the dollar or the South African currency conversions, but you'll notice that the average of 2,115 in some states like Chandigarh, Uttarakhand and Rajasthan, and Manipur, Nagaland, Himachal Pradesh and Daman is far greater to what, in fact, the Chandigarh and Uttarakhand is almost practically double the amount that we see as average expenditure of India. So one of the reasons that we have this challenge in India is because of the reason about that most of the people, our database actually looked at the disability component, and we also try to understand whether insurance. So India has a very low insurance coverage, and most of the mental illness is also handled at an outpatient level. So insurance typically in India do not tend to cover any kind of outpatient expenses. The other reason is also that if somebody has got a diagnosis of mental illness, then insurance companies tend to reject that, those kind of expenses, even if the person is insured. So they have a kind of a double burden. They not only have the disease, they don't only have the mental illness, but at the same time, they are also affected with the additional cost due, and because of which there's a huge number of population that go below poverty just because they have to manage the expenditure around mental illness in India. This is another study that is currently ongoing along with some members in India. And here we are again using a different data set. It's called the longitudinal aging study in India data set. This data set actually looks at only people above 45 years. The previous slide that I mentioned had adults only, so it was everybody beyond 18 years of age. In this case, and these are just initial estimates, the paper is analysis and paper is currently being written. So I've just pulled out what are more relevant for the discussion today. And from our analysis, initial analysis, we found that the age, which is 45 to 59, which is essentially the early, which is the early 15 years productivity age left, because typically in India, people retire at the age of 60. then you also notice that the higher age groups, the higher productive age group are more prominent compared to more than 60 years, which almost accounting to 68.2% of the overall hospitalizations and 61.9% of the outpatient cases. And taking the same age group, if I continue with the expenditure, it almost comes on yearly expenses of 52,000 Indian rupees, which is roughly around $818 per year, with a monthly outpatient cost of $27 or 1,763 rupees per month. So you'll also notice that for this age group, which is probably the age bracket in which your income starts going higher, if anybody is affected with anxiety or depression, then their expenditure on healthcare also goes up. And I'm sure that because of the shift of need for this health and also of their mental condition, some of them might lose their income or probably their jobs. So it also affects a loss of income. So it becomes like a double, triple burden where not only you on one side you are affected with depression. On the other hand, it might impact your income in terms of number of work days lost or sick leave, but you also have the burden of additional expenses. So that's the triple burden that populations in India which are affected with depression are currently getting exposed to. If you take a different category, which we try to put above 70 years, then we found that compared to the lower age group between 45 to 69, we found that comparatively to that population, 70 years or above are more likely to experience catastrophic health expenditure for hospitalization, with almost 38.4% of the population facing catastrophic health expenditure at the 10% threshold and almost 12.3% at the 30% threshold. And these numbers are very important because if a household is exposed to catastrophic health expenditure due to one particular individual being affected with depression, it is also very high probability that those households will end up becoming poor, just because of the need to manage those mental health conditions. And these are important because in India, for medical related expenditure is actually the third most cause for people being poor. The first being, the other two factors being employment and loss of other loss of assets. Medical expenditure in India is considered to be the third leading cause for people to get poor. So what can be done? So if in India, we do not have this kind of return on investment, so I've taken an example from a similar country, which is kind of a LMIC called Philippines. So Philippines did a study which was conducted by the UNDP, and they found out that if in Philippines, the current burden of mental health condition affects almost 2.7 billion PHP in terms of direct medical costs and almost 66.2 billion PHP in terms of indirect costs. If you have to handle, and this total together cost actually contributes or affects almost 0.4% of the overall GDP. So to handle this huge burden of mental health condition, the investment that is required from public sector and all other sources will be almost 143 billion. And if you take that investment over, and what they've done is they've also segregated them into various mental health aspects such as anxiety disorders, depression, bipolar, epilepsy, alcohol use, school-based, and also both universal as well as indicated. So if the country invests around 143 billion as an investment for clinical packages over a 10-year period, the return on investment will be more than double. You'll notice that the return on investment over a 10-year period is actually going to be $217 billion, which is roughly almost 2 times, almost double the amount that the country will benefit. So while the expenses are there, I think India might need to learn from this in terms of trying to have more investment towards managing mental health, because not only are you by these investments are you not only getting the productivity improved, but you're also getting the life years gained. And a lot of people who are affected with mental illness get their incomes kind of lowered because of their impact due to their employment issues. So making a investment case for improving mental health access and treatment and management, but also preventing would be a way forward for countries like India and South Africa. Thank you. I'll stop here in case any question.
Thank you, Denny. Should we have questions together in the end, or should we have for each session? If there is one question, we can allow one question now. Is there any question, or we can put the questions in the chat and we can take it forward? Is there any question? All right. Since just going forward, we'll keep the chat open for questions. Before I go on to the next speaker, I'll introduce, because I didn't have the bio, I'll introduce the co-chair of this session, Dr. Kagisho Marugene, who's the head of the unit of the district specialist psychiatrist team working in Ekurhuleni district. He's also board member and public sector national convener of the South African Society of Psychiatrists. Additionally, he's a senior lecturer at the Department of Psychiatry at University of Witwatersrand. I hope I pronounced everything correct.
Nice, fine.
Shall we go on to the okay. Shall we go on to the next speaker, sir? So the next speaker is Dr. Geeta Menon. She'll be talking about the experience during COVID-19 in terms of especially the social stigma and the mental health issues. Dr. Geeta Menon is a senior scientist trained as a biostatistician working for Indian Council of Medical Research, National Institute of Medical Statistics in New Delhi. She has a large experience in biomedical research. She has a doctorate degree in biostatistics and a significant experience of analyzing data from large-scale surveys and epidemiological studies, doing statistical modeling and undertaking systematic reviews and meta-analysis. She's a recipient of the ISCB Young Scientist Award in 2006, Dr. Kelly Big O'Keefe Academician and Researcher of the Year Award 2013, Statistical Alliance for Vital Events, Queen Elizabeth Advanced Scholar QES 2018, and Indian Society of Medical Statistics BG Prasad Award 2020. She has co-authored over 115 publications in national and international journals. Dr. Geeta, please, we invite you to
Good afternoon. Good afternoon. Am I audible? Am I audible?
Yes, you are.
Okay. Shall I share my screen?
You are.
Yeah, I think I am not allowed to share my screen. Can I be given the access to share my screen, please? Post disabled participant screen sharing.
Just a moment, ma'am. Yes, surely we'll provide you. Yes,
Yeah.
you can share now.
Yeah.
Okay. Hope my screen is visible. Is it visible?
Yes,
Yes,
ma'am,
yes.
it's visible.
Yes.
Good
Yes.
afternoon to all of you, and thank you, Dr. Chitra, for introducing me. I am supposed to speak on mental health of healthcare workers during COVID-19. We all know that COVID-19 had inundated our health system to the extent that today we have about 770.4 million cases worldwide and 6.95 million deaths across the world. And India accounts for about 5.8% of the confirmed cases across the world and about 7% of deaths that happened across the world. Healthcare workers were the ones who faced the major challenges in managing COVID-19 patients, primarily because of the novel nature of the disease, the conflicting alternatives of the treatment, the fear of infection of self and their loved ones. There was a shortage of personal protective equipment in the early stages of the pandemic. They had long hours of work in their hospitals, and that created difficulties for them to emotionally and ethically triage and allocate resources to the patients. So then, taking this as the premise, ICMR task force project was started in September 2020. This was a 2-month project in which the primary aim was to assess the occurrence of psychological distress among healthcare workers who were engaged in the management of COVID-19 patients, and also gain some insight on their burnout levels, which nobody had done at that time in India. We took about 10 sites for our study that roughly covered all the regions of the country, the north, south, and the east-west region, and we also covered the northeastern regions of India. There were 10 centers, and these centers covered a total participant group of about 967. The health workers that were involved in the study were those who were engaged in triaging, screening, treatment, isolation, referral services, and community outreach services. And they were doctors, nurses, pharmacists, ambulance workers, community workers, housekeeping staff, lab staff, hospital attendants, and almost all those people who were directly or indirectly involved in the management of the patients. We, since it wasn't possible for us to do a face-to-face interview, we did a telephonic interview. The site-specific investigators called up the participants, and we created a Google form for them, which included all the personal background, their job-related work, related to the management of COVID-19, COVID-19 patients, their hours of work, the types of activities they were involved in, and to assess their risk of psychological distress, we used the General Health Questionnaire 5, which is a shortened form of the GHQ 12, and this provided an indication of those individuals who could possibly be at risk of psychological distress. The GHQ 5 had 5 questions that covered their loss of sleep, whether they were feeling constantly under strain, whether they were able to enjoy their normal day-to-day activities or not, were they feeling unreasonably, reasonably happy all the time, or they were feeling sad or depressed, and whether they were also feeling unhappy and depressed. So the respondents, this was a simple questionnaire to respond to, and they were expected to respond with either a yes or a no. And the risk of psychological distress was taken as someone who had a GHQ score of more than, greater than or equal to 2. In addition to that, we also tested the burnout questionnaire, which is actually is similar to the Maslach burnout inventory. We could not use a Maslach burnout inventory primarily because it was priced at that time. We did not want to spend money on purchasing this, and it would have taken more time to get this in a proper channel. So ICMR, National Institute of Occupational Health, had developed a burnout questionnaire for Indian settings, and we in fact used this questionnaire in our study also, which was about a 19-item questionnaire with 3 domains covering the emotional exhaustion, the depersonalization, and personal accomplishment of the participants. And based on the scores given to these items in each of these domains, the participants were categorized as ones who had burnout, they were overextended, they felt they were ineffective, and they were disengaged, or those ones who had low scores for all these items, and therefore were called the engaged group, which was a positive group. So this shows the analysis that we did. It was a logistic regression analysis in which the types of activities were directly correlated with a higher risk for psychological distress. As you see, the ones that has been marked here, those who were involved in contact tracing and screening were the ones who were at risk of getting a higher possibility of having psychological distress. The other analysis we did was to look at the socio-demographic factors which could possibly have an effect on the risk of psychological distress, and we found that those who were better paid, like the doctors and the nurses, those who spent more hours in the clinic or hospital, more than 8 hours, and those who had low scores of emotional exhaustion, those were the ones who were found to be at higher risk of being psychologically distressed. Then we also looked at the burnout scores, and we tried to see whether there was a higher percentage of people who were having a higher score for emotional exhaustion. Although this graph doesn't show that, it shows that most of the individuals responded to having been satisfied with their work, or they were enjoying and they were happy with the work. They did not feel sleepless, they did not lose appetite, they did not keep thinking about the work related issues in general in the emotional exhaustion section. We found that overall, when we looked at the burnout scores, we found that about 9.7% of the healthcare workers that we had covered had burnout, and many of them were, a good percentage were totally engaged. That means they had no burnout symptoms in their workplace, but many of them showed they were overextended or disengaged, or they were disengaged and ineffective, and many of them felt that they were ineffective because there was a reduction in their personal accomplishments. We also did a psychological qualitative study to look at and to see whether the psychological challenges that the healthcare workers faced were related to their work, family, and their personal well-being, and what were the associated stigmas. We also tried to get some insight on the coping mechanisms adopted by them and their perceptions of interventions to address these challenges. So the qualitative study was not done on all the 967 participants. We did it on 111 healthcare workers. The interviews were taken, and the interviews were then transcribed using a thematic approach, and it was analyzed in NVivo software. The data were analyzed, and the emergent themes were organized across different constructs, like impact on their work life, impact on their family life, impact on their sense of well-being, coping, and their perceptions on coping, and suggestions were also taken from them on how to mitigate the stigma due to COVID-19. So what came out of this qualitative study was, I'll discuss a few of them. Work-related issues. When they looked at the changes in the work routine, they found that there was a big change in the roles and responsibilities that were given to them as compared to the usual routine. For example, one doctor said that with COVID, there is an additional stress related to their work. Earlier, once they received an emergency call, they know what they were dealing with. But now, when there is an emergency call and they go to the casualty to attend the patient, they have to be in their PPE first, and that itself caused a lot of discomfort. And if the patient was COVID positive, then the patient is sick, he had to be given emergency care, and the emergency procedures have to be used. There was an increased workload. They felt that that increased workload led to stress. Somebody said that, like the ambulance worker says, that there is a lot of pressure and we were overloaded with work, and we get too tired and we get angry too, because we had to deal with public, especially those who don't understand the situation. And the erratic work timings was another reason for their increase in psychological distress. There were challenges with the PPE. Almost all of them felt that wearing PPE for a long time made them feel suffocated, and it also it is just being covered by a plastic bag, and they felt breathless and excessively sweated. The fear of infection was anyway there, and that triggered these stressful emotions. Separation from families, because they felt that if they get affected, then they would have left a small baby at home. That baby may also get affected. They had elderly parents living with them, and they might also get affected. So they mentioned all this in their verbatim response. They most of them felt there was no time with the family because of the busy schedules. There was a fear of infecting the families, and many of them could not disclose that they were doing COVID duties to the family, because that could have increased the pressure in the family. So at the individual level, they felt that sleep deprivation because of the increased workload. Many of them felt that there was an increased risk of sleep deprivation with the constant worry about work and experiences at work. There was a disruption in the eating habits. Many of them had to skip their food because they were wearing PPE kit for long hours. At the social level, stigma and rejection, people around them made them feel that they were the spreaders of COVID-19 infection. And some of them said, when people see me, they say, "Here comes Corona." And the neighbors would close their doors and windows as when they see them coming from a distance. Even in marketplaces, people covered their faces when they saw the health worker. So these were some of the challenges that the health workers faced. The coping strategies that the health workers adopted was one from the family and the friend support. All the participants reported that they were able to cope with the challenges primarily because of a good support from their immediate family members and friends, and also those who were engaged in the COVID-19 duty with them. The peer support was also there. There was a strong sense of support from the colleagues, and since they all worked as a team, whenever they faced a problem, they could discuss it with the team. Some of them also felt that they could cope up with the tension or pressure with listening to music or do yoga for a small time or do some prayers. So the conclusion from this study was that at all levels, the COVID-19 care services faced various challenges in their work life, in their family life, that affected their well-being. And the study also provided some insight on the kind of interventions that the health workers perceived could be taken to address these psychological challenges and at the organizational, societal, and individual levels. So this study, apart from this study, there were other studies done by other countries also, and they have used various other tools to address the issues. Like some of these studies have used the GAD-7, which is a 7-item validated screen for generalized anxiety disorder, following the DSM-4 criteria. Then some other studies have used specific instruments for addressing the sleep patterns of these individuals, and these individuals were also subjected to other types of instruments to measure their role limitations due to the emotional problems, and SF36 version 2 was used. And for depression, some of the studies had used patient health questionnaire PHQ-2 and PHQ-9, and many other studies across the world had used around there were about 3,000 articles. I just searched the PubMed and I found that there were 3,000 articles on mental health of healthcare workers. And these studies have used post-traumatic stress disorder that was measured using the PTSD questionnaire. Now, what I would now suggest is that I got hold of one systematic review that was not done on COVID-19, but it almost covers all those issues that the health workers faced during the COVID-19. And this systematic review summarized that the factors that increase the risk of adverse psychological outcomes, if we are looking at the clinical factors, it could be the increased contact with patients, precautionary measures that impedes the job, there is forced redeployment and higher risk among the nurses. People with inadequate training and those who had less experience with lower levels of education increase the risk of psychological outcomes. And in the personal section, if, or I mean the personal factors, if a person was single, younger, and with, if she was a female, there was a higher chance of higher risk of adverse psychological outcome. Increased time in quarantine and staff with children and infected family members again increase the risk of adverse psychological outcome. Persons with low perceived personal self-efficacy and those with a history of psychological distress or mental health disorders or substance abuse had a higher risk of adverse psychological outcomes. And if you're looking at the service factors, perceived lack of organizational support, perceived lack of adequacy of training, lack of confidence in infection control in the hospitals that they were working, and also some of them felt that no compensation was given to the staff for this increased workload. And societal factors are the societal stigma. All these factors increase the risk of adverse psychological outcomes. And the factors that
Dr.
yeah,
Geeta,
have I crossed my time?
I think we are crossing. Yeah,
Okay,
yeah.
okay. I'll
I
just
think,
quickly summarize. The factors that reduce the risk was the frequent short breaks, um, greater experience through years, more training, more supportive staff, more supportive peers and family, and also reduce the infection levels in the hospitals. And there is a general drop in, if there is a general drop in disease transmission, which was not under our control anyway, to reduce the risk. This paper also recommended what should be done to reduce the levels of psychological distress, and if there was a good support, and if the healthcare workers were given encouragement from their peers and given sufficient rest and time off, it could possibly reduce and mitigate the mental health problems of the healthcare workers. So that's
Okay.
yeah,
Yeah.
I am covered.
Thank you so much, Dr. Geeta. That was a wonderful, I mean, like the study that we all did together. And also it was good that you brought in other studies across to look at how other people have also done the studies and also the tools that they have used for various psychological conditions, which is very important if you are planning any other study as well, especially which are very useful when there's a humanitarian crisis as well. So I would, is there, I'll give time for one question, otherwise we'll just get on with the next presentation, and then we'll have some time last so the speakers can stay back and we can have the questions finally. I can't see, there is a question from Urvisha Bhura, Dr. Geeta. Did the study look at substance use patterns of the healthcare workers as a coping mechanism? There is increased alcohol consumption.
No, we did not. No, we did not look at the substance use patterns among the healthcare workers per se. But I think that would be a good idea. But since you all know that during that period it was very difficult to get all that information directly from a telephonic interview, so we could not do that.
Yeah, and I think in the qualitative interview, people did not actually come out with that coping mechanism. Maybe one person also, but it didn't emerge as a strong theme in terms of substance use. That's what I also remember. So shall we? Thank you, Dr. Geeta. we'll go on to the next speaker. I'll just get the. Okay, the next speaker is Dr. Purnima Sundar. She is the Clinical Director of MEHEC Foundation, a not-for-profit organization working with vulnerable communities. She is presently engaged in delivering community mental health care services through 23 clinics spread across 5 districts in Kerala. Under her leadership, a multidisciplinary team ensures accessibility of quality care at grassroots level by establishing partnerships with multiple stakeholders, including local self-government, that is panchayats in India. She is currently leading an ICMR-funded research project to understand the key determinants of community engagement in mental health services. She'll be talking about MEHEC, on MEHEC as a case study. Dr. Purnima, I invite you to start here.
Am I audible, ma'am?
Yeah, you are.
Hope my slides are visible.
Yes.
Good afternoon, everybody, and thank you, Dr. Chitra, for the introduction. So today, my topic is about MEHEC as a case study. So moving on, this will be what we'll be covering through the 15 minutes talk today. Going back to the history. So our history comes from the palliative care movement. The palliative care movement in Kerala was a community-based model, which could reach out to a large population, mainly through voluntary work. And over time, it has been proved to be one of the sustainable models of community-based models. So our founder, Dr. Chitra, was part of this initial team. And during a home visit with palliative team, she saw a glaring lack of services for people living with mental illnesses who were not able to reach out to these services, which were available at few places at that point in time. Hence, the idea of long-term care for people with mental illness started taking shape, and with a vision to build a community in which every person has access to affordable mental health care of good quality, and a mission to develop a new model of long-term mental health care by strengthening existing healthcare systems and improving community participation. MEHEC started its work. Now, just to give you an idea of how long it has been working in the field, we were registered in 2008, and in the same year, clinics were started in northern part of Kerala. It mainly worked with palliative care units in northern part of Kerala at that point in time. And later on in 2010, there was a shift to central and southern part of Kerala. The clinics that were already running were handed over to a like-minded organization, which is still continuing the work and has expanded. So in 2010, after moving to the southern and central part of Kerala, we started off with the one panchayat clinic and 2 palliative NGOs. Cut to today, in 2023, we work across 5 districts with 23 clinics being active. And over the years, we have handed over, MEHEC has handed over about 20 plus clinics. This is, in short, how we started working and what has been happening over time. Now, just to give you an idea of how exactly do we work. So MEHEC is a community-based mental health care program, which borrows a lot of principles from palliative care, and it is rooted in those beliefs. So palliative care principles with long-term care with focus on quality of life through compassionate holistic care, which is rooted in relationship-based connectedness, which is supported by a democratic multidisciplinary teamwork. This is what guides us throughout every work we do, and it is evident in every part of what we do. So here, if you look at our process, the client as well as the caregiver is central to our activities. So we see family as a unit of care, and this in turn is helped by multiple stakeholders, including a multidisciplinary team, which I would be talking about later, the community members, which involves trained volunteers, as well as people who volunteer their time for the cause, palliative care team, which is present at every panchayat level in Kerala, panchayat being the local self-government bodies, and community health workers who are trained workers and who supports these programs. So we need funding to run an organization like this. So it comes from like-minded people who are either individuals. There are certain government bodies like the panchayats are the LSTs that we work with. There are corporate institutes and other like-minded NGOs who help us run this process. Now, what exactly happens? So if you look at the other side, I've written about understanding the community. So what I want you to also understand is that these multiple stakeholders are a part of each and every aspect of what we do. So whether it is understanding the community, the resource identification and strengthening of it, the empowering community or individual care plan, eventually aiming for community ownership as well as community reintegration. It plays the multiple stakeholders play an integral role in this. So what exactly is MEHEC's role? MEHEC is actually the expertise role wherein we do the need analysis, help develop a service model for the particular community, keeping the community's needs in view. We run clinical services, and we also do advocacy and training programs in this area. MEHEC as an organization also looks at replication and sustainability of its programs, and the ultimate aim is to actually transfer the ownership back to the community. So this is in gist of how we go about doing what we do. Now, just introducing you to the team. We are headed by the board of trustees, followed by a managing trustee. We have a comprehensive team which across disciplines, a clinical director who is also the psychiatrist, general physician, clinical psychologist, as well as psychiatric social worker with the team of social workers aid in the work. There is the operations side of the work is managed by an operations lead along with the finance and admin person, the office administrator, as well as driver. So everybody works together as a team to make what we do possible. So about the work, I was thinking we can go back to our basic questions of where, who, what, and how. So I'll just walk you through a few of the things. So where we work, so this on the side you can see the map of Kerala. So the Kerala is in the southernmost part of India, and we work across 5 districts in Kerala. So the states are further divided into districts. And in these 5 districts, we run about 23 clinics at present with involvement of panchayats. We have about 8 panchayat clinics currently running. With other NGOs, we have about 8 clinics, and there are other like-minded organizations which do support us. So what do these stakeholders do, our partners do? They provide the physical space or the infrastructure for the consultations, as well as they help us with the medication. So they bear maximum of the cost, and they do the funding for the services. And they do coordinate at various levels in the community, and how exactly we go about doing it, I would be introducing you to the same. So who do we exactly see? Who does MEHEC see? So as of now, since the beginning, we have had about 4,500 patients who have been registered with us, and many more lives have been touched. Like I said, family is the unit of care for us. There are at present 1,100 plus active patients. A majority of our patients belong to lower socioeconomic status. So just to give you an idea of the socio-demographic in terms of the males and the age group. So majority of our patients are females, that is more than 60%, and males are about 40%. And if you see, we also have a major number of aging population who are 60 plus. Kerala is an aging state. So we do have multiple problems in the elderly that we see on a daily basis. And as you can see, the other major illnesses that are prevalent, that the age groups are also more. Now moving on to what exactly do we see in them? What we see, MEHEC's focus, since it was mainly for a long-term care model, was on severe mental illnesses and making care affordable for them. So what you see here is that whether it is irrespective of the gender, our major clientele is suffer from severe mental disorders, which is nearly 46%, followed by dementia in women is on the higher side in the clientele that we see. Common mental health disorders, so was not our focus, has always been a part of what we do, since we believe in providing a holistic care. And we are also seeing that post-COVID, there has been a rise in the people consulting for common mental health disorders as well. We do see other neurodevelopmental as well as neurological disorders. Substance use disorders, if you see, might be less represented here, but it is because of the nature of work we do in the community and stigma associated with substance use, or people less help seeking associated with substance use. Now, moving on, what is the work and how do we go about doing this? This is something I'd hope that if you were here or if you were visiting us would have given more clarity. However, I'll try and attempt to walk you through what we do. So I've included a lot of pictures to give you an idea of what we do and to also give a cultural idea of who we are. So coming to the clinics are run within community settings. So what does it mean? Our clinics don't look like typical hospitals. As you can see in the picture, some of it is office space, some of it is volunteers' houses, some of it is a primary health center. So it is in multiple settings that we do this. So why do we do it in such settings? It is basically the space provided for us by the community itself. And this space, what is unique about it is that it makes it more affordable and accessible. Affordable in terms of it is lesser travel for the patients, and also we do spaced visits. This is something we have learned post-COVID, and we cover up the rest of the things through tele-follow-ups and home care visits in between. The consultations are free and the medications are made available free. It is accessible, and it also becomes a setting for them to meet, and which in turn has helped us reduce stigma. The home care visits ensures that the care is delivered at their doorsteps. There is individualized psychosocial interventions because we can understand the psychosocial issues better. And overall, what it does is it reduces the cost of illness for the patient and their family. It also helps in reducing stigma. As the community sees a group of people coming and interacting, they do engage with them more. And this is always done with by a multidisciplinary team, including community members. It could be a palliative nurse or a ASHA worker. There is somebody from the community who is always engaged in these works also. Other than this, we also run support groups. So support groups we have started for caregiver support groups as well as for patients. In caregiver support groups, finding certain things has been challenging for us, especially the space and consistency of participants. However, we have been able to consistently do it over the past few, almost more than a year now. And patient support groups have also ensured that there is better activities of daily living being followed. They are more active and there is more interaction among them. Now moving on, we also have a Home Again project. So this is in collaboration with Banyan, which is another NGO which works in especially for homeless mentally ill. So the concept is of again reintegrating them back into the community. So these are people with mental illnesses who are mainly either homeless or cannot be taken care of by their families. As you can see, it's not just about finding their vocational aspects, it's about sharing the time, it's about celebrating, it's about living a normal life as in any other home. So that is the aspect that Home Again is envisioned, and reintegration is done through this vision. Coming to capacity building, we do it with across the board, across different stakeholders, including community health workers, the medical officers, hospital staff, community volunteers, panchayat members. What we have seen is that involving the elected representatives is a very important part of capacity building because they have a lot of say in what happens on the ground. We do a lot of awareness and advocacy programs, and various activities are carried out throughout the year regarding this. It's not just taking awareness classes. We also do street plays and other activities and reach out through various other forums. Here, certain things that we have done in the recent past has been taking care, especially focus on elderly as well as problems of children. And we have conducted multiple awareness programs for the same. We also do research activities that is in line with the work we do. And we are looking at, currently we are looking at role of community engagement in mental health care model at local self-governance level. We keep saying community engagement works. So now we need to understand what about it works. So what have we learned so far? The strengths have been that we work at grassroots level. There is a lot of community engagement, which makes the program sustainable. There is family involvement, which in turn has improved quality of life of people, and the focus on quality of life has ensured that there is a better community reintegration as well as adherence. And the democratic teamwork is what makes it possible to pull it through. It hasn't been short of challenges. The challenges are mainly what any other NGO in this space would be experiencing. It is mainly manpower. Getting people willing to work in the community who are trained enough is difficult. Retaining is again difficult, but we have been able to do it. Socio-political will in terms of, I think another speaker had also mentioned it, when it is an NGO, there is a lot of apprehension about who they are, what will they do, and how will it be. So it is sometimes difficult to get through to them. Funding is a big area that is one of the major concerns. Having an exit plan ready and being able to execute is another concern. Stigma, though reduced from before, has always a concern. So what we have learned is that through community engagement, most of our challenges can be managed and can be dealt with more effectively. Regarding impact, it is very difficult to be unbiased about what you do. So I thought I should get back to some of my patients' words and see what they had to say. So this is about one of our clients, Mr. K. If you can see on the top, there is a house. So this house, when we started seeing him, did not have an electricity connection. He was staying there with his wife, and they had and they were in abject poverty. So from there, what we did was support them over the last 3 years, and now they have moved to a old age home as a couple, and we were able to sort of facilitate that process. What you see on the side are the things that he made. So eventually, when he was living in the old house, this was used as a coping by him. We would provide the raw materials for the same. Now back in this new home, he is able to sort of earn a living as well as cope by making these crafts that he does. And he says that he's happy, and it is very visible on their faces now. I think for us, impact is that the connections that you make and the change that you can make in your own ways. So that's what Mehek does, and I hope I was able to sort of summarize what we do. Any questions? Thank you.
Can you stop sharing, Purnima? There's a question for you. Dr. Sundar, do your services cover mental health awareness in schools? This would complement the activities you do in the community.
Yes, we have covered in the past as well in schools. So there have been about 5,000 plus schools that are school children that we have sort of approached for awareness trainings. In future also we do have plans for the same. I think the time was short, so there was a lot of difficulty in putting everything that we do together.
Yeah, I think the team is also planning to start a child and adolescent clinic in one of the districts to enable that after awareness. So there are new programs also coming up. Thanks, Dr. Purnima. Any questions? Doctor, can we go on with the next speaker, Doctor, who's sharing? Can you introduce? Do you want to introduce? Dr. Marogani? Sir, would you like to introduce the next speaker? Do you want to, Doctor, getting him through to him? Let us go on to the next speaker.
Good afternoon, yes. The next speaker, I thought since you are already the chair, you're gonna introduce the next one.
Shall I go on to the next speaker then? It's about the community-oriented substance use program in South Africa, a case study by Dr. Urvisha
Pura, yes.
just a
There she
minute.
is.
Dr. Urvisha Bura is a specialist family physician with the University of Pretoria. She is a clinical lead of the community-oriented substance use program COSUP in Swane, Pretoria, and is responsible for the clinical oversight in COSUP. She has presented on various platforms and published articles in both national and international journals. She is a member of INHSU-MCR, that's the International Network on Health and Hepatitis in Substance Users Early Mid-Career Researchers Executive Committee, and is a review of articles for various journals. Dr. Urvisha, please, we invite you.
Thank you so much. Thank you for the introduction and the opportunity to present on this platform. As the introduction says, I'm Urvisha Bura and I'm a family physician. I'll be talking about our program, COSUP. So, as a start, just so that we have an understanding, substance use is a global phenomenon, and we know that people who are socially and economically disadvantaged are more likely to develop a substance use disorder. So according to the WHO Global Drug Report, it also showed that the estimated prevalence of drug use in Africa was more than the estimated global prevalence in 2018 of the rest of the world. And we also know that the prevalence amongst men is higher than women. Unfortunately, only 1 in 8 people with a drug use disorder actually receives treatment each year. So substance use disorder, as defined by the DSM, is a pattern or patterns of symptoms resulting from the use of a substance that you continue to take despite experiencing problems as a result. And the DSM also recognizes that these substance-related disorders can occur as a result of use of 10 separate classes of drugs. The diagnosis is made from 11 criteria, and this is further subcategorized according to severity as mild, moderate, or severe. So besides a diagnosis of substance use disorder as per the DSM, we also recognize that people are in different patterns of use. So people who use substances move along a continuum of use, where some people might be in experimental use and others in dependence, or a person can be in different stages of use with different substances as well. So substance use and mental health, we know that it is a DSM diagnosis, and we also know that they commonly occur and together have impacts on healthcare outcomes. This is not only healthcare outcomes to the individual, but also on healthcare systems. Two of the previous speakers also mentioned increased costs when it comes to managing healthcare. And when you add the complexity of substance use together with that, it definitely adds a burden on healthcare systems. So there's 2 studies that were published from South African hospitals, which the one in Gauteng province showed a 67% prevalence of substance use disorder amongst acute psychiatric patients. And another study in the outpatient department in the Eastern Cape showed the prevalence of ever use and past year use of psychoactive substances as well. When we look at mental health and substance use in homelessness, we know that these are significant factors that affect homelessness. And published data from Tshwane in South Africa, March of this year, looked at the prevalence of mental health symptoms among street homeless people living in Tshwane shelters during the lockdown. And this used the DSM-5 cross-cutting symptom measure, where 295 participants who were in homeless shelters were interviewed, and the DSM-5 symptom measure was applied. And this study showed a variety of mental health issues. Substance use formed the largest burden, which is 202 of the 295 substance users. 295 participants. Anxiety fell second, personality dysfunction, and then depression and sleep problems. So, it's clear that substance use can be very problematic and it can affect mental health. And when we ask ourselves, why do people use drugs? It's not a complex answer. And so therefore our solutions are not simple. Dr. Naicker spoke about protective and risk factors for mental health. And I think in the same way, we look at protective and risk factors for substance use. So why do people use drugs? This ranges from dysfunctional family environment to pre-existing mental health conditions where people are self-medicating, as well as to develop a sense of belonging. When people cannot establish connections with healthy things, then very often they form connections with unhealthy things like substances. So in order to reduce the harm of people who already have an existing substance use disorder, we practice harm reduction, which is an essential evidence-based, internationally accepted and recognized set of healthcare practices. And these are aimed to minimize the negative health, social, and legal impacts associated with drug use. So the idea is to minimize the harm from all substances by allowing the user to make informed decisions around their use, because we also understand that it is not practical for some people to stop using drugs immediately without a change in their lifestyle or socioeconomic circumstance. And so for some people, drug use is also a way for them to manage their trauma. So when we approach health services, we very much focus on a community-oriented primary care approach, which is an active partnership between healthcare providers and healthcare user. And the model is very similar to what the previous presenter presented as well. And I smiled when I looked at that because I saw quite a few similarities in that model and what we are also providing in Tshwane. So the idea is designed with the individuals and the families in their homes and the communities in which they live in. And in the homeless population, this does look a bit different because people are not necessarily at home, but they are also situated within communities. Even the homeless population is a community of their own. And so this still creates opportunities to improve their health and access to services. So our specific program, the Community-Oriented Substance Use Program, is an initiative between the City of Tshwane and Metropolitan, as well as the University of Pretoria, Department of Family Medicine, and it was implemented in 2016. The City of Tshwane is our main funder, and it is the only South African metro or state facility that is funding a substance use or harm reduction program. We do follow a harm reduction philosophy in those who are substance users or have the disorder, but we also promote demand reduction. We have 16 outpatient sites in the City of Tshwane. 11 of them are also situated in the communities within NGOs, within churches, within any available structure, and 5 of them are located in health facilities. Each of our sites are managed by a team of staff members with varying skills and qualification. We are service delivery based with a research focus. The objectives of our program are to create an inclusive, enabling environment that is non-stigmatizing of substance users. Previous speakers have also talked about the stigma surrounding substance use as well as mental health. So our program encourages the destigmatization and sensitization of substance use in the communities. We would like to prevent, detect, and manage comorbidities and improve the quality of life of substance users, their families, and the communities in which they live. So the services provided at each of our sites include screening and brief interventions. We use the WHO Assist 3.0 screening tool, which is the alcohol, smoking, and substance involvement screening tool, which gives you a risk level for different substances and interventions based on the risk levels. Medical examinations and treatment is provided, counseling service, opioid substitution therapy for opioid users, needle syringe services for injecting drug users, HIV, TB, and STI screening, and we are soon to introduce syphilis testing at our sites. We also offer psychosocial services as well as linkages to skills developments that are available in the communities. So how we function, we also have a lot of community outreach, awareness campaigns, and education done in the communities as well as in facilities. We receive a lot of walk-ins and referrals. At our first contact, the service user would receive information on the services, and an assist will be performed based on the findings of the assist and on the needs of the service user. Brief interventions and motivational interviewing will be conducted, and a collaborative plan will then be developed. As needed, medical evaluations, including HIV counseling and testing, TB screening, and syphilis testing will be done, and management is referred out as necessary. Then, based on the risk, so people who are at high risk of harm are offered services that then reduce the harm. So how this looks is those who are injecting would be offered access to clean needles and syringes, education on safer injecting practices. And at the moment, we're also seeing an increase in crystal methamphetamine use, which has significant mental health implications. So a lot of harm reduction is done in crystal methamphetamine use. Opioid users would be offered opioid substitution therapy, and all service beneficiaries would be encouraged to join ongoing and individual counseling sessions provided by the social workers at the sites. Family intervention and support groups are also provided, and then there's linkages to skills development in the community. A new, or not a new, but something that we are very passionate about is care coordination. So very often we find that when patients are referred either up levels or when they are down referred, they very often get lost in a system. Systems can be intimidating, systems can be stigmatizing, systems are not always accessible for the end user. And so the idea is to really improve the coordination of care for a user so that when they are referred through different levels of care, that they are well managed and that the person referring is able to follow up and ensure that the clients are seen. And how we've done this is to build a relationship with clinics and health facilities and other stakeholders in the communities, but also to enable that the down referral system is also a system where we can catch patients when they are referred or when they are discharged from hospital. So we are essentially working on bridging the gaps between discharge and home, as well as bridging the gaps in the referral process. Something that we are working on now is a helpline or a hope line, which will benefit the user and the healthcare provider, where we are involving key stakeholders within community settings, health facilities, communities, all those engaged in healthcare services, so that we develop an extremely efficient transdisciplinary network. And this will assist us in bridging these gaps. So opioid substitution therapy at our sites is provided as maintenance therapy. We do not do detoxification. The recommendation according to literature is maintenance therapy for the management of opioid use disorder. And our exclusion criteria is only any medical contraindications to opioid substitution or previous allergy, and anyone under the age of 18 years. So how we initiate medication, after baseline evaluations and the assist is conducted and all contraindications are excluded, we use either methadone or Suboxone or buprenorphine naloxone combination. Methadone is our first line medication, and the buprenorphine naloxone combination is only reserved for those with contraindications to methadone. We aim to achieve a maintenance dose after about 2 weeks. And once maintenance and stability is achieved, then we aim for weekly decans, and patients are also encouraged to continue with psychosocial support. And once they are able, they're also encouraged to join a skills development program. Our medication is managed according to Schedule 6 regulations. We've got multiple SOPs, and the medication is written monthly per individual prescription and dispensed weekly by our private pharmacies. So as I mentioned, methamphetamine use has been on the increase, or it has become more prevalent that we've seen. And so what we're seeing is that when it's used in excess or very harmfully. It can cause severe mental health effects, where it can cause to hospitalize. We can lead to hospitalization, where most patients are admitted with a substance-induced psychotic disorder secondary to methamphetamine use. And anecdotally, many facilities in our areas have up to 80% of their acute psychiatric cases being secondary to SIPD. So we really are focusing to strengthen harm reduction concepts around methamphetamine use, as well as improving linkages to mental health services. Our stats for this month show that our needle exchange, distribution, and collection, it's more than 100% of return rate, because we've had to decrease the numbers of needles that were distributed this month compared to last month due to budget and resources. We've got 721 people on substitution therapy, 107 support group meetings were held, and 753 beneficiaries attended support groups. As I mentioned earlier, we are service delivery based, but we also have a research focus. So I didn't list all of our publications, but these are our publications just for 2023. And it ranges between use of opioids and HIV services in correctional services, retention of users, mental health amongst the homeless population, as well as the use of methadone for acute opioid withdrawal. Okay, thank you so much.
Thank you so much, Dr. Urvisha. That was very interesting, and substance use is actually a great need in the community, and such services make a great difference to the quality of lives of people. We have a lot to learn from your program. Any questions to Dr. Urvisha? If not, we should just go to the next speaker. I'll be just inviting the next speaker. I see that the co-chair is having network problems, so I take it as my responsibility to go forward. The next speaker is going to speak on yoga and mental health. Ms. Karish Bhim, psychologist and yoga specialist. I'll just introduce her. I don't have her. Okay, I get it. Karish Bhim has a BA in industrial psychology at the University of Witwatersrand. She also has a diploma as a yoga instructor. She's the official instructor for the Indian consulate in Johannesburg for several years. She's a Miss India Gauteng winner. She's a registered holistic wellness counselor. She conducts public yoga demonstrations for socio-economic development, health, and mental well-being. Ms. Karish Bhim.
Good afternoon, Doctor. Thank you so much for the introduction. Could I please share my presentation?
Sure. Are you finding it difficult to share?
Yes, my apologies. I'm just trying to share.
Mr. Parnita, can you help her?
We have
Amrit?
already given her the sharing option. So
She doesn't have the sharing option?
yes, she does have it, the sharing option.
If you can
Kirish, you
share,
can
send
email to
the
me.
power.
Or Kirish, you can email to me. I can share for you if that is easier.
My apologies, Doctor. Perhaps we can do that. For some reason, it's saying it doesn't support PowerPoint. My apologies for that.
Just
Could we
email to
perhaps
me.
move to the next speaker while I just send it to you?
Or we can have the next speaker speak, and then you can actually send it, and then we can do it after that speaker. Is that okay with you?
Thank you. Thank you for that. I'll send it immediately.
All right. So I will ask the next speaker to get on with this topic. I'll just introduce you, Dr. Prashanta. Just give me a minute. So the next speaker is going to talk about mental health status of health professionals and managers after Balasura train accidents in the state of Odisha in India by Dr. Prashanta Roy, Institute of Psychiatry, Kolkata. Dr. Prashanta Rao is the head of Department of Clinical Psychology, Institute of Psychiatry, a center of excellence in Kolkata, India. He's a licensed clinical psychologist with 18 years of teaching experience and has published over 35 national and international publications. His specialties include disaster mental health, psychological trauma management, cognitive behavioral therapy, and interpersonal therapy. Dr. Prashanta Roy.
Yes, madam. Thank you. Thank you for the introduction. And good afternoon, everybody. Am I audible?
Can you share your presentation, sir?
Yes, I'm sharing. Yeah, hope it is visible.
It is visible. You can proceed.
Yeah. Yes. Good afternoon, everybody. I'll be discussing about some conceptual issues related to psychosocial disaster care. And it is important because if you look at the Asia Pacific region where almost all kinds of disasters are there, and if you look at the history of last 20 years, the overall disasters are on rise, and probably Asia Pacific region is considered as one of the the most significant zone where the disaster in comparison to the other place of the world is on rise. And if you look at India, in last 20-30 years, almost all kind of disasters have happened, starting from earthquake to the flood. And if you come to the background of the current incident, current case study, where the recent triple train disaster happened on 2nd June 2023 at around 7 p.m., which is around 300 plus kilometers from the city of Kolkata, where 3 trains collided at around 7 p.m. Indian Standard Time near Bahanagar Bazar railway station, which is a very small railway station of Balasore district in the state of Odisha in eastern India. And if you look at the other informations, the official report says there were around 300 deaths. It was, to be precise, 294 deaths, though the local people said there might be more. And there were around 1,200 people who had significant injury in this accident. In one particular train, that is Coromandel Express going towards Chennai, in the particular train, 21 bogies got derailed. And local people took the charge of the rescue from the Bahanagar village area. Around 5,000 people, local people, all the adult people, they gathered to help the people in the night. And at around 9 p.m., the rescue team reached, and they started their operation, and throughout the night the local people also supported the rescue team. Dead bodies were kept in the Bahanaga High School and almost for 3 days. Injured people were transferred to the Balasore Medical College, which was around 30 kilometers away from this particular accident zone. And in the neighboring cities, also later on, some of the injured people were transferred, and also in the state of West Bengal. On behalf of Medical Service Center, we initiated some of the activities. Medical Service Center is a socio-medical voluntary organization, stand by the people in times of distress and disaster, and it is functioning since 1978, the flood disaster in West Bengal. And Medical Service Center has been providing its medical support in many of the major disasters, starting from tsunami to earthquake to the including the Nepal disaster, the earthquake disaster in 2015. We did a significant work in Uttarakhand flood in 2013, Kashmir flood in 2014. Even in recent flood last year also in Odisha and West Bengal, the organization was supporting. And since the tsunami in 2004-5, the Medical Service Center started focusing on the psychological aspect of the disaster. So MSC volunteers, it is a national level voluntary organization. So almost in all the states, there are some volunteers. Mostly those volunteers are the medical students or the medical professionals or the nursing professionals or paramedical professionals. Even some of the rural practitioners also, they are part of the Medical Service Center volunteers. And so from the Balasore district, the volunteers provided the medical support in the accident area after the particular accident, and after that even to the local people. And these particular volunteers reported the psychological issues in the healthcare providers who gave their support. And so we planned a visit at Balasore Medical College as we learned that the students and the interns of that particular medical college, and they had significant psychological issues. And after visiting it there, we did some focus group discussion in the medical hostel with the interns and the students. Many of the students, they left the hostel by that time. There are two reasons. One reason was because they were feeling psychological trauma. So the college administration thought that probably if they are sent to their home, that would be helpful. And second issue was there was a particular festive season was also about to come. And we found that a large number of MBBS senior students and interns, nurses, pharmacists, they were involved in this, dealing with this death and injured people. Almost all had traumatic stress reactions. Almost all the students in this focus group discussion, we had around 20 medical students, and all of them reported a problem in their sleep, a problem in their intrusion of the thoughts and images, the startle reactions, increased heart rate. And some of them had significant emotional reactions, including flashback, increased heart rate, and many of them reported for last 4-5 days, and they were unable to sleep at all. And there had been the report of significant fear in them, because many of them are also believer of ghost. So people who had the students who had significant emotional reaction, acute stress reaction, they restrained themselves from the service after the first day, and some left for their hometown also because of this significant issues. And however, the guilt was prominent who stayed in the hostel after that, but they were not giving any kind of services. They reported that they were feeling guilty. They were reporting that my friends were going and providing service, so I'm unable to go there because of my fear. So it is a kind of a feeling of shame that I have thought of becoming a doctor. So I don't deserve to be a doctor. So this amount of guilt was quite prominent. So what was our primary focus was to communicate them that these are all normal reaction to the abnormal event. And in this process, we discuss about the various kind of trauma reactions, like what are the cognitive reactions, like decreased concentration, intrusive thoughts and images and memories, forgetfulness, nightmares, even flashbacks. And we also discuss about the emotional trauma reaction like fearfulness, guilt, anger, irritation, sadness, anxiety, disconnectedness, particularly. And some of them might be feeling numb. And the bodily trauma reactions like disturbance in the sleep, appetite, energy level, gastrointestinal disturbances, increased heart rate, body muscles are tense. And then we discuss about the role of psychological first aid and its component. What are the components that we explain to them and how it can be helpful to them also, as well as after they learn the concept of psychological first aid, they might help their peer members also. A few students or interns came up with significant trauma reaction individually, and we dealt individually with them, try to provide the necessary psychosocial support. A training on psychological first aid in the evening was planned after the visit of the Bahanaga High School. And then we went to this Bahanaga High School where around 300 dead bodies, official sources around 300 dead bodies, unofficial sources around 500 dead bodies had been kept in this particular school. And dead bodies were kept in two big size classes. The picture on the down, these are the classes. Those classrooms were destroyed after we visited. Because even after the removal of the dead bodies and after doing the proper cleaning, it was smelling, the blood spots were there, and students particularly were quite fearful about going there. As school principal reported that fear of students was quite prominent to join the school due to the fear of ghosts and traumatic images, and they believe were a ghost. And some faculty members expressed their concern regarding their own traumatic reactions also. So we had again a focus group support and discussion with them. And role of normal reaction to abnormal event was addressed, and we suggested that following a normal routine and breathing exercise can be quite helpful to reduce their arousal level. And we also discussed about how to help the students to form a positive association or positive images with the school. And so we suggested them if they can and plan, there is a festival, Rath Yatra, that was coming up. And so we suggested that if some Rath Yatra program can be taken in the school ground, which is outside the school campus, or maybe some sports can be planned, some drawing or play activities can be planned involving the family members, because family members also had significant emotional issues. And after we made the visit there, then in the evening we started the training on psychological first aid. It was a very brief training of 3 hours in the hostel itself. That was attended by medical students, interns, and pharmacists. And plan was how to help the other students in distress to peer support. And we assume that when we are part of the solution, that means when we are trying to help the others, actually we are helping ourselves. I am no more part of the problem then when I am part of the solution. And we primarily discuss on the 3 components of psychological first aid. One is looking for whether they are feeling safe, looking for what kind of emotional reactions they are having at here and now, what kind of cognitive reactions, what are the biological reactions, and what are the behavioral reactions they are having now. And teaching them how to actively listen to the people when they are expressing their distress, and then how to provide a link. And we discussed about 3 links. The first link was about normal reaction to abnormal event. That was the first link that will help the people to minimize the burden, because many people feel that probably I'm weak, that's why I'm suffering, I'm becoming mental or mad. So we try to normalize it by telling that these are all normal reactions. Not having this kind of reactions may be abnormal. And second link about if there are any family members or friends with whom they can discuss their distress, who can provide some kind of support. And third link about the administrative help, the link. We did number of role plays to teach them how to go for active listening and how to provide the necessary support. Another visit was planned with the emphasis on local mobilization of the professional community. Various online interaction with the psychologist of Odisha state were made after that particular training. Many members of the Indian Association of Clinical Psychologists, they also got involved into this discussion, who had some training in psychosocial disaster care. Our webinar was planned on psychological first aid by the Mental Health Institute, SCB Medical College, Cuttack. It was attended by around 110 local psychologists from Odisha state and 20 from the outside state. And the aim was particularly to give them a particular a tool on how to provide the basic grassroots level of support, and that can be continued in the community level. And after that, local professionals, including the psychology students, including the clinical psychology, psychiatric social work, and psychiatrists, and the local professionals continuing their support with weekly visit to the Bahanaga school area. And now the issues are mostly normalized. So these are some of the activity-based observations that I wanted to share. Thank you.
Thank you so much, Dr. Roy. It was a disaster which shook the whole nation. And any such humanitarian crisis leads to psychological trauma as well. Can you hear me?
Yes, yes.
Yeah. So I can understand that evidence is very important, so that we learn from it, and then one is the intervention part, and one is that such evidence also helps us in planning and preparing for the next crisis that we face.
Yeah, yeah.
And this kind of interventions also help us for other mental health issues in children and adults, and especially suicide and substance use, as we have been discussing. Thank you so much. Any questions to Dr. Roy? Please stay, Dr. Roy. Maybe we'll have a question later. Can we have Kairish Bean talk? Are you ready? Yes. All right.
Good afternoon. Good afternoon to everyone, our esteemed doctors and professors and members of the JBA board. Thank you, Dr. Jayati, for sharing. Sorry about earlier. Thank you for giving me the opportunity to comment in this symposium. Just quickly, I have been teaching yoga for 15 years nationally and internationally, so I have noticed quite a significant impact on mental health in both children and adults. So as we know, there has been an increase in mental health problems over the past 5 years. Although modern medicine is most prevalent today, many people still opt for more traditional or homeopathic methods of healthcare, such as yoga and Ayurveda. As most of you should know, yoga is an ancient art form originated from India, and many of its ideologies have been adapted into modern day life. Yoga consists of yoga asanas, pranayama, mudras, and meditation. And the reason why we're looking at yoga in terms of mental health, in terms of statistics, I think this was mentioned earlier by the World Health Organization that in 2019, nearly a billion people, including 14% of the world's adolescents, were living with a mental disorder. Suicide accounted for more than 1 in 100 deaths, and 58% of suicides occurred before the age of 50. And mental disorders are the leading cause of disability, causing 1 in 6 years lived with disability. So this is according to WHO. Yoga has become a household word today, and it's practiced worldwide. I think everyone has a few elements of yoga in their life, whether it's just the simple exercises or simple meditation techniques. We've all adapted a few exercises as part of our daily routines. And it's become so popular that we even have an International Yoga Day, which is on the 21st of June from the year 2013. So of course, we can see that it does have a worldwide benefit of which people appreciate and participate in. So why is yoga effective in mental health? And of course, we know the answer is yes. It has an immediate positive impact on anyone, whether it's a child or an adult. And this presentation will touch on the scientific research associated with the effects of yoga on mental health, which prove its worth in today's mental health care field. So just quickly about the definition, the term yoga is derived from Sanskrit word yug and means union or a method of spiritual union. Yoga originated in India and is a behavioral practice that unites physical and mental training aimed at improving health and promoting personal transformation with the ultimate goal of attaining samadhi or pure consciousness. According to Patanjali's sutras, yoga encompasses the following 8 aspects or limbs, which are yamas, ethical guidelines, abstinence from immoral behavior, niyamas, which is self-discipline, asanas, which is physical postures, pranayama, which is breath control, pratyahara, which is sensory withdrawal, dharana, which is concentration, dhyana is meditation, and samadhi, which is ultimately pure consciousness. So this is the ultimate goal in the practice. But of course, this takes many years to achieve. We are trying to instill the basic principles of yoga, and we're trying to teach those basic principles. Of course, the level and intensity of the yoga practice does differ from each individual practitioner, but the goal is to start the process, which is immediately beneficial in managing mental illness. So because of these wonderful side effects of yoga, many people have incorporated it into their daily exercise regimes. Exercise and meditation are now also popular tools used in the health and wellness industries and companies. And a lot of these ancient techniques have been modified to apply to modern day life. All right, we can move on to the third slide, please. Okay, so is yoga effective on mental health? I think that was the previous one. So from a few of the research papers that I have used, if anyone is interested, I can attach the bibliography later on. We have found consistent findings which include increased gray matter volume in the insula and hippocampus, increased activation of prefrontal cortical regions and functional connectivity changes, mainly within the default mode network. There is quite some variability in the neuroimaging findings that partially reflects different yoga styles and approaches, as well as sample size limitations. Direct comparator groups such as physical activity are scarcely used so far. Finally, hypotheses on the underlying neurobiology derived from the imaging findings are discussed in the light of the potential beneficial effects of yoga. These results are congruent with morphometric neuroimaging of meditation practitioners, where it was found that increases in the insular cortex were the most consistent structural alterations across meditation styles. So in essence, it is proven that the brain is activated during yoga and meditation, and there is a significant neurological structural change in continued practice. So we can go on to slide 4, please. So this is just a common yoga sequence for immediate results. It's quite a basic routine, which is easy for even a child to practice. I'll quickly explain each asana. And this particular routine is beneficial for memory and concentration. So again, take note of the sequence. It is done in a particular order for about 30 minutes. Some of you may know some of these asanas if you do practice yoga. This one is Vrikshasana, Tadasana, or the tree pose. It develops physical and mental balance, clears congestion of the spinal nerves. Next is Paschimottanasana, the seated forward bending. This one is very good for yoga therapy, and it helps in everything from prolapse to diabetes. It's actually one of the most important asanas in yoga therapy. Then we have Bakasana, which is the crane pose. It's more of an advanced pose. And once a practitioner does get to this level, it balances the entire nervous system. Next, we have Sarvang Asana, which is the shoulder stand pose. This one stimulates the thyroid gland and it balances the nervous and the endocrine system. And of course, as medical practitioners, you know how important it is to regulate the thyroid gland for hormonal control. And then lastly, we have one of the most difficult yoga asanas, which is called Sirsasana, or the headstand pose. This is the most advanced pose. And of course, it brings blood flow directly to the brain, and this aids with the pituitary gland, also relieves anxiety and other psychological disturbances. So I just wanted to touch on exactly what's happening in the brain and the chemicals that are released during this. We can go on to slide 5. So yoga on the brain. As a part of our research, we want to be precise about the parts of the brain that are affected or activated by the practice of yoga. There have been a few studies related around this. Yoga has an immediate positive effect on a physiological level, but it also has shown to restructure the neural network and synapses with regular practice. And this happens from child to adult.
Can we move the slide?
Can you please move on to the 6th slide?
Next one, please.
Which parts? Sorry. A little bit back. The parts of the brain that are affected.
Is it this one, Keris? Because sometimes you talking like extended, so I cannot follow. Is it this slide you want?
My apologies.
Yoga on the brain.
We're on number, so we're on slide number 6 now. It's the actual brain scan, the one with the picture.
One with the picture.
Yes,
okay,
with
so the previous
brain
one.
scan.
Okay.
The next one.
What is the title of the slide? Because I don't see the number, so I can only read the title.
It's the one after this, so just click the next one. Yeah.
Click the next one even. Now
the
it's
next one,
showing
it says
yoga on the
research
brain.
theory.
This one.
Correct. Thank you so much. Perfect. Okay, so here we can see the actual brain scans. I'm not sure if you can read the writing, it's a bit small. So here we see what parts of the brain are affected by yoga. Of course, here we're working with the actual neurobiology, and this is improvement in homeostasis of the body, the spinal cord, and memory and voluntary control, central nervous system. So the control of the body's internal environment to remain homeostasis, and this is also to regulate the body temperature. Then also programming of spinal cord reflexes. Excuse me. An example of this is in the stretch reflex. The flexibility of the spine is of utmost importance in our health. And then lastly, memory and learning, voluntary control of movement. So yoga, of course, assists in all of this. The technique of neuroimaging the brain was used to determine the physical effect on the brain. According to the research done by Frontiers in Integrated Neuroscience, they reviewed 34 international peer-reviewed neuroimaging studies of yoga using magnetic resonance imaging, the MRI scan, positron emission tomography, PET scan, or single photon emission computed tomography, the SPECT scan. Our review of the yoga imaging literature suggests that behavioral mind-body interventions, such as yoga practice, can affect the anatomy of the brain. Yoga practice appears to be linked to anatomical changes in the frontal cortex, hippocampus, anterior cingulate cortex, and insula. So here, when you look at the diagram and the image, you can see with the colors highlighted the areas that were affected and which chemical release it was. So what chemicals are released during yoga? During yoga, your brain releases all sorts of chemicals that not only help you relax, but also lower your stress and anxiety levels, including the gamma-aminobutyric acid, GABA, dopamine, oxytocin, serotonin, and endorphins, which is your happy mood, your happiness. So why is this chemical release so important in our mental health? Research has shown that changes in yoga and meditation have positive effects on the brain. Participation in these activities has been linked to better cognition and emotional well-being. Yoga triggers the release of chemical gamma-aminobutyric acid, or GABA, a neurochemical responsible for regulating nerve activity. Okay, so now we can go into slide 7. So now that we know that yoga definitely does have an effect on the brain, how do we actually go about making it something that's automatically memorable for someone to do automatically? And that's where the practice actually comes in, where it becomes something that people do unconsciously. They're unconsciously aware of how they standing, how they're breathing, what their posture is, and that's the aim. So in Africa, we've done a lot of work in Africa and a lot of yoga activities and a lot of yoga programs. Myself, working with the consulate, we've worked with many underprivileged communities and trying to promote a better socioeconomic standard for them. Many people across cultures and nations have incorporated yoga into their lives. And I think in South Africa, we have a very family-orientated culture, which is why it makes it easier for people to like yoga and very easy for them to participate in it. Since the inception of International Yoga Day, we've had a great response, and there are literally thousands, hundreds of thousands of people in Africa that participate every year. So we can definitely see that it is working, and they are a success every single time. So it has become a way of life for many people and has proven to bring people together for the right reasons. When you do yoga, your brain cells develop new connections and changes occur in brain structure as well as function, resulting in improved cognitive skills such as learning and memory. Yoga strengthens parts of the brain that play a key role in memory, attention, awareness, thought, and language. And next here in slide 8, which is what the secret or the secret science to happiness is. Many people think that yoga is just about doing exercises, but as we can see by looking at the evidence from the brain scans, it really is a physical science. There is something chemically happening in the brain when people practice yoga. I thought it'd be nice to just quickly include a little bit more of an advanced yoga routine for adults. This is one that adults practice for advanced brain power. Also to maintain as we grow older, it becomes harder. Our memory, we start losing our memory and things like that. So this is a nice yoga routine. It starts off with Padmaasana. It's called the lotus pose. This is a very good exercise that has a very relaxing effect on the nervous system. The next one, it's called Ardha Matsyen Asana. It's the seated twisted pose. This one is very good for regulating secretion of adrenaline and bile. So again, having a healthy body and a body that is functioning properly, of course, helps in your mental health. Next here we have Vajrasana, also the diamond pose. This assists with altering the flow of blood and nervous impulses. And lastly, we have Halasana, or the plow pose, which stimulates the thymus gland and also helps to stimulate the immune system. And again, Paschimottanasana.
Ms. Bain, you have only 3 minutes more. You have only 3 minutes more.
Excuse me?
You are coming close to your time. You have 3 minutes more, I said.
Oh, my apologies. Yes, we always finished. Just going through quickly, I can just rush through these slides. So in India, I'm currently working with an NGO for underprivileged women and children, where we work with indigenous communities in helping them with their basic needs and basic education. This year, it's my mother and I that run this NGO, and she's currently in North India working with a few indigenous communities from Nepal to Guwahati. And what we've noticed with a lot of them is that they don't have the resources. Nobody really goes out there. A lot of these schools and a lot of these communities, rural communities, are in the jungle, and it's very difficult for anyone to get to them. But they're so enthusiastic, and they're so open to to yoga and learning all of these different meditation techniques, it really helps them to deal with the stressful conditions that they're living in. Basic things like water and electricity, are such a privilege for these children. And we've watched them, we've seen, just doing yoga with them on a daily basis, how it helps to motivate them. They're happier, they have more energy. It just helps them all around. And I think in conclusion, we can say that yoga definitely has a positive impact on both the body and the mind. And we do and have realized that more training and more development is needed, especially in our underprivileged communities of India and Africa, to help people to practice. The interest is definitely there, but it's just about us being able to provide the funds and the resources to help these people to learn. I hope that this does give you a better understanding of what we can do to try and grow yoga in India and South Africa. Thank you again, everyone, for your time and for listening. Have a lovely afternoon. Thank you. Good afternoon.
Thank you so much. Thank you so much for your interesting talk. Any questions to Karish Bean about yoga?
May I ask a question?
Yeah.
May I ask a question?
Please.
Yes. No. Thank you, Doc, for that insightful talk. I appreciated how when you said that some parts of India are not accessible, so offering yoga as an alternative in the meantime, something that you're doing. And I think it's quite good that we need to think beyond just medication and admitting patients, but what other alternatives we can give. But I'm wondering, do you think that yoga is stigmatized because of the name itself, and any thoughts of maybe renaming it into something else, perhaps that will make it more palatable, for lack of a better word? Thank you.
Karish?
Good afternoon. Thank you for your question, Doctor. Yes, I understand what you're saying, and I believe that there is a stigmatism attached to it. But at the same time, I think we do need to appreciate where the knowledge comes from. And as we have seen, yoga has been taken across the seas. It's actually become more of a Western thing. In America, a lot of yoga practitioners have changed a lot of the names and adapted it to a more Western or more modern way. And I don't think that there's anything wrong with that, so long as the essence of yoga isn't taken out of it. So I hope that is able to answer your question.
It does. Thank you very much.
Thank you so much. Thank you, Dr. Maraganya. We have come to the last bit of today's webinar as a speaker. We have one session on voices from the field, and we have one volunteer who works in a district called Palakkad in Kerala with Mehek, Mr. Keshav Das, who we can see on the screen. We call him Unieta, that means like a brother, and he is one of our most strongest links to the community program that we do in his area called Ellapulli. I invite Mr. Keshav Das to speak about his experience. If he's speaking in Malayalam, that is our language, I will translate it. If he's speaking in English, then that's fine.
Ma'am, will he be presenting anything? Do we need to give him the sharing option?
No. Unieta, PowerPoint undo? Illalo? സംസാരിക്കാനല്ലേ പോകുന്നുള്ളൂ? സംസാരിച്ചോളൂ. Going to talk, Dr. Paramita.
Okay, thank you.
ഞാൻ ലാസ്റ്റ് ഒരു 15 വർഷമായിട്ട് പാലിയേറ്റീവ് സർവീസിൽ ഒരു വളണ്ടിയറായിട്ട്, ഒരു സാധാ വളണ്ടിയറായിട്ട് വർക്ക് ചെയ്യുന്ന ഒരാളാണ്. എനിക്ക് പറയത്തക്ക മെഡിക്കൽ ബാക്ക്ഗ്രൗണ്ടോ അങ്ങനെ ഒന്നുമില്ല. സാധാരണ ഒരു കമ്പനി എംപ്ലോയി ആയിരുന്നു. ആ സമയത്ത് തന്നെയാണ് ഞാൻ ഈ സോഷ്യൽ സർവീസിലേക്ക് ഇറങ്ങിയത്. ഞാൻ ഒരു വളരെ വളരെ സാധാരണ ഒരാളാണ്. എനിക്ക് ഈ മെഡിക്കൽ ഫീൽഡായിട്ട് യാതൊരു ബന്ധമില്ലാത്ത ഒരാളാണ്. ഞാൻ ലാസ്റ്റ് ഒരു 15 വർഷമായിട്ട് ഈ പാലിയേറ്റീവ് സർവീസിൽ ഒരു ഓർഡിനറി വളണ്ടറിയായിട്ട് വർക്ക് ചെയ്യുന്നു. അതിൻ്റെ അടിസ്ഥാനത്തിൽ ഞാൻ ഗ്രാമങ്ങളിലാണ് എൻ്റെ സ്ഥലം. ഗ്രാമങ്ങളിലെ ഏരിയയിലാണ് ഞാൻ പാലിയേറ്റീവ് സർവീസ് ചെയ്യുന്നത്. അപ്പൊ ഗ്രാമങ്ങളിൽ എനിക്ക് ഒരുപാട് ഫേസ് ചെയ്യേണ്ടി വന്നത് ഈ മാനസിക രോഗികൾക്ക് ഒരു തുടർ പരിചരണം, അവർക്കൊരു കെയർ കൊടുക്കുക എന്നുള്ളൊരു ആശയമാണ് എൻ്റെ മനസ്സിൽ ആദ്യകാലങ്ങളിൽ ഉണ്ടായത്. അങ്ങനെ ഇരിക്കുമ്പോഴാണ് ഞാൻ മെഹക് ഫൗണ്ടേഷനിലെ ഡോക്ടർ ചിത്രയായിട്ട് പരിചയപ്പെടുകയും അദ്ദേഹത്തിന്റെ ഒരു ഫ്രീ സർവീസ്, അവരുടെ ടീമിന്റെ ഒരു ഫ്രീ സർവീസ് ഞങ്ങളുടെ എലപ്പുള്ളി പഞ്ചായത്തിലേക്ക് അവര് തരാന്ന് ഉറപ്പു തരികയും അതിന്റെ അടിസ്ഥാനത്തിലാണ് ഞാൻ മെഹക് ഫൗണ്ടേഷനായിട്ട് കൈകോർത്തത്. ഞാനല്ല, ഞങ്ങളുടെ സ്നേഹതീരം പാലിയേറ്റീവ് കെയർ യൂണിറ്റ്. അപ്പൊ ഇന്ന് സ്നേഹതീരം പാലിയേറ്റീവ് കെയറും മെഹക് ഫൗണ്ടേഷനും ലാസ്റ്റ് 10 വർഷമായിട്ട് നമ്മൾ ഈ ഫീൽഡിൽ മാനസിക ആരോഗ്യ പദ്ധതിയിലേക്ക് ഞങ്ങൾ വർക്ക് ചെയ്തുകൊണ്ടിരിക്കുകയാണ്. എൻ്റെ എക്സ്പീരിയൻസ് വെച്ച് പറയുകയാണെങ്കിൽ എനിക്ക് വളരെയധികം സന്തോഷം നൽകുന്ന ഒരു പ്രവൃത്തിയാണ്. ഞാനാണ് അത് കൈകാര്യം ചെയ്യുന്ന ഒരു വ്യക്തി. ഒരു വളണ്ടിയർ നിലയ്ക്ക് മാനസികാരോഗ്യ പദ്ധതിയിൽ സ്കീമിൽ ഞാനൊരു ഫുൾ ടൈം ഒരു വർക്കറാണ്. നിലവിൽ ഞങ്ങൾക്ക് ഒരു 100ഓളം പേഷ്യൻസിനെ ഞങ്ങൾ ഈ ലാസ്റ്റ് 10 yearsൽ കണ്ടിട്ടുണ്ടായിരുന്നു. അതിൽ ഒരു ലൈവായിട്ട് ഇപ്പോഴും ഒരു 60ഓളം പേഷ്യൻസ് ഇപ്പോൾ ലൈവാണ്. ഇതെല്ലാം ഞാൻ പറയുമ്പോൾ ഒരു അതിശയോക്തി നിങ്ങൾക്ക് തോന്നും, പക്ഷെ സത്യം അതാണ്. ഒരു 20-25 വർഷമായിട്ട് മാനസിക രോഗം വന്ന് വീട്ടുകാരും നാട്ടുകാരാലും ഒറ്റപ്പെട്ട് കഴിയുന്ന വ്യക്തികളെ അവരുടെ വീട്ടിൽ ചെന്ന് കണ്ട് അവർക്ക് വേണ്ട ഡോക്ടറുടെ കെയറും മെഡിസിൻസും കൗൺസിലിങ്ങും ഞങ്ങൾ ഫ്രീ ആയിട്ട് സപ്പോർട്ട് ചെയ്തുകൊണ്ട് ഇന്ന് ആ രോഗികളെല്ലാം, ആ പേഷ്യൻസ് എല്ലാം, അല്ലെങ്കിൽ നമ്മുടെ നല്ല ഭാഷയിൽ പറയുകയാണെങ്കിൽ നമ്മുടെ ക്ലയൻസ് എല്ലാം നോർമൽ സ്റ്റേജിലേക്ക് ആൾമോസ്റ്റ് അവരുടെ ദൈനംദിന കാര്യങ്ങളും വീട്ടിലേക്ക് ഒരു ഏണിങ് ചെയ്യുന്ന രീതിയിലേക്ക് അവർ വന്നിട്ടുണ്ട് എന്നുള്ളൊരു ചാരിതാർത്ഥ്യം ഞാനൊരു വളണ്ടിയർ നിലയ്ക്ക് എനിക്ക് അങ്ങേയറ്റമുണ്ട്. അപ്പോൾ അതിനെനിക്ക് അവസരം നൽകിയ മെഹക് ഫൗണ്ടേഷന് നന്ദി പറയുകയാണ്. ഇങ്ങനൊരു ഓപ്പർച്യൂണിറ്റി എനിക്ക് തന്നതിനും എനിക്കും സ്നേഹതീരം പാലിയേറ്റീവ് കെയർ എലപ്പുള്ളി പഞ്ചായത്തിന് തന്നതിൽ ഞാൻ അങ്ങേറ്റം സന്തോഷം. ഇന്ന് ഞങ്ങൾക്ക് ഞങ്ങളുടെ ക്ലയൻസ് എല്ലാം, ഞങ്ങളുടെ പേഷ്യൻസ് എല്ലാം 98% അവര് മെഡിസിൻ കഴിച്ചിട്ട് നോർമൽ സ്റ്റേജിലേക്ക് പോയിക്കൊണ്ടിരിക്കുകയാണ്. 1-2 പേഷ്യൻസിന് മാത്രമേ നമുക്ക് കുറച്ച് പ്രോബ്ലം ഉള്ളൂ, ബാക്കിയെല്ലാം വളരെ നോർമലായിട്ട് പോവാണ്. ഡോക്ടർ കൂടുതൽ എന്തെങ്കിലും പറയണമെന്നുണ്ടെങ്കിൽ ഞാൻ പറയാം.
നിങ്ങളുടെ മറ്റു റോൾ പറയൂ, എന്ന് വെച്ചാൽ എങ്ങനെ ഇത് മാനേജ് ചെയ്യുന്നതെന്ന്, പൈസയുടെ കാര്യവും ഫണ്ടും, എന്നുവെച്ചാൽ ഇത് നിങ്ങളുടെ പ്രോഗ്രാം ആണ് എന്ന് പറയാനുള്ള കാര്യം. എന്നുവെച്ചാൽ ഞങ്ങളുടെ അല്ല, മെഹക്കിന്റെ പ്രോഗ്രാം അല്ലല്ലോ, നിങ്ങളല്ലേ നടത്തുന്നത്?
കറക്റ്റ്, അതെ, ഞങ്ങൾ തന്നെയാണ് നടത്തുന്നത്. പക്ഷേ ഇതില് മെഹക് ഫൗണ്ടേഷനായിട്ട് ഞങ്ങൾക്ക് ടൈപ്പ് ചെയ്ത് അവരുടെ സർവീസ് പറഞ്ഞാൽ അവരുടെ മെഡിക്കൽ ടീമും അവരുടെ സൈക്കോളജിസ്റ്റ് ടീമും ഫ്രീ ആയിട്ട് ഞങ്ങൾക്ക് തരുന്നു. ബാക്കി എല്ലാ മെഡിസിൻ എല്ലാം നമ്മളാണ് പ്രൊവൈഡ് ചെയ്യുന്നത്. എല്ലാ പേഷ്യൻസിനും നമ്മൾ കറക്റ്റായിട്ട് മെഡിസിൻസ് ഫ്രീ കോസ്റ്റ് ആയിട്ട് കൊടുക്കുന്നു. അതിന് പുറമെ അവരുടെ ഫോളോ അപ്പും നമ്മൾ ഫ്രീ ആയിട്ട് ചെയ്യുന്നു. അവരുടെ വീടുകളിൽ ചെന്ന് വളണ്ടിയേഴ്സ് നിരന്തരമായിട്ട് ആഴ്ചയിൽ ഒരു പ്രാവശ്യമെങ്കിലും ഒരു പേഷ്യന്റിന്റെ വീട്ടിൽ ചെന്ന് അവർ പ്രോപ്പറായിട്ട് മെഡിസിൻ കഴിക്കുന്നുണ്ടോ ഇരിക്കുന്നുണ്ടോ എന്നുള്ള കാര്യങ്ങളൊക്കെ നമ്മൾ മോണിറ്റർ ചെയ്യാറുണ്ട്. ആ വിവരങ്ങൾ അപ്പം നമ്മൾ ഡോക്ടേഴ്സ് ഷെയർ ചെയ്യാറുണ്ട്. ഡോക്ടർ അതിനനുസരിച്ചുള്ള ഫീഡ്ബാക്ക് തരാറുണ്ട്. ഇത് ഞങ്ങളുടെ റൂറൽ ഏരിയയിലൊക്കെ ഇത് വളരെ എഫക്റ്റ് ആണ്. ഇപ്പോൾ പണ്ടൊക്കെ ഞങ്ങളുടെ നാടും പുറത്തൊക്കെ ഒരു മാനസിക രോഗം വന്നു കഴിഞ്ഞാൽ സത്യത്തിൽ അവര് ഏതെങ്കിലും അമ്പലങ്ങളിൽ പോവുകയോ അല്ലെങ്കിൽ ഏതെങ്കിലും സ്വാമിമാരത്ത് പോയിട്ട് ചരട് കെട്ടുക, അങ്ങനെയൊക്കെ പതിവായിരുന്നു. ഇപ്പോൾ ഈ നമ്മുടെ പഞ്ചായത്തിലും നമ്മുടെ ചുറ്റുപറ്റുള്ള പഞ്ചായത്തിലും ഒരു മാനസിക രോഗം ഉണ്ടെന്ന് അറിഞ്ഞാൽ അവർ തീർച്ചയായിട്ടും ഫസ്റ്റ് അവർ എന്നെ കോൺടാക്ട് ചെയ്യാനും നമ്മുടെ സ്നേഹിതരായിട്ട് യൂണിറ്റിൽ കോൺടാക്ട് ചെയ്യാനും നമ്മുടെ ഡോക്ടർ സർവീസ് ആവശ്യപ്പെടുകയും ചെയ്തിട്ടുണ്ട്. അത് വലിയൊരു അച്ചീവ്മെന്റ് ആയിട്ട് ഞാൻ കാണുകയാണ്.
ശരി, ഞാനിതൊന്ന് ട്രാൻസ്ലേറ്റ് ചെയ്തോട്ടെ. If you can see, I have actually translated in the chat also. If people want to read, I'll read it also. So this is Mr. Keshav Das. He said repeatedly that he's an ordinary person in the community, very ordinary, has no medical qualifications. He's a non-medical person working in a village. He has been working in palliative care and he has been on the field for the last 15 years. He also, because when he started doing home visits, he wanted to start some service for mentally ill people also. And then he met the Mehek team. And now we have a good service for mentally ill people in our village. I am coordinating this program full time. We have more than 100 persons with mental illness the last 10 years. We have single people, isolated, homeless people. We go to their homes. We offer free services. Most of them have improvement in their quality of life. They have started functioning well. 99% of the people that we take are much better. We take care of them, monitor them. They are very compliant with medication. We run the program with a close ties with the HEC team who offers free service to us. We do the home visits, follow up by volunteers, monitor if they're taking medicines, if they have any symptoms or side effects. Earlier, we used to approach faith healers, but now people are approaching us for getting mental health care, and I think that is a huge achievement. Any comments on this? So that is from a volunteer from the community. If people have anything to say, please do. And we have come to the end of this webinar. And we have some, Dr. Jayati Basu says, excellent work, Huneta. So, excellent work.
Thank you, sir.
And I think Mehak also relies so much on the community people to continue and sustain a program. So we also are very thankful to these teams which work endlessly and tirelessly in the community with they don't grumble, they do it out of their own passion and commitment to the people who live along with them. And I think that is a great sense of solidarity with the community that they live in. Anything else? Any questions? Or if there are no more questions, we can wind up the session. Is that okay, Dr. Paramita?
Can I come in?
Dr. Mararanya, yeah, please. Yeah, please do.
Yes.
Please
No. Thank you very much for this workshop. I think what I'm picking up is obviously there's a lot of technical work that we normally expect from academics, from medicine. But what I'm also appreciating is that certainly in India, there seems to be a use of other methods of trying to help patients' mental illness. Acknowledging the fact that, the spirituality there that you need to take care of, the use of volunteers like we just heard, and also previously the use of yoga. So I think in that way, it's acknowledging the patients and the population that you have and giving them a different set of offerings, unlike just giving them medication and expecting that it'll solve all the problems. So well done to that approach. Thank you.
Thank you, Dr. Marina. Dr. Paramita, can you wind up the session with a vote of thanks?
Yes, madam, sure. First, I would like to thank all the speakers for having a we had such enlightful sessions, and I would like to thank each one of the speakers for giving us insights into the mental health problems, both in India and South Africa. So I would like to thank the chairperson of the first session, Dr. Nantembiso, and the welcome address was given by Dr. Edith. I would like to thank her. She introduced us to the mental health problem that we are facing now and why it is important to address it, the various challenges that we are facing currently. Then introduction to JPI Ekurhalini was given by Dr. Jayati, and then JBI CPHR was introduced by Dr. Denny John. Thank you so much. And then Professor Hugo was chairing the second session. Thank you so much, sir, for chairing the second session. And Dr. Chitra led us through the community mental health situation in India. She introduced us to the various challenges that are existent there. So thank you so much, ma'am, for introducing us to the various community mental health problems that we face in India. Dr. Naikar also led us through the mental health problems in South Africa. We found that there were many similarities in the Indian and the South African situation. Thank you so much for the sessions. And the next session was chaired by Dr. Chitra on evidence on mental health. Here we had Dr. Denny John speaking on the economics of mental health. He told us how the mental health has its impact on the economy at large, which is very important in the discussion. And then we had various we had Dr. Geeta speaking on the mental health and the social stigma associated with it. She shared her study on the COVID experience. It was a very interesting study. It did us with many insights. And then we had many case studies discussed. The Mehek case study, it was an interesting study. And then the South African case study and the Indian case study associated with the Balasore accident. And then we had the field experience from the Mehek volunteer. So these gave us glimpses of the grassroots realities, which are really took us to the actual situation and the various problems and challenges that are existent. We got to learn through this a lot, and I would like to thank all the speakers. And we also had a very interesting session on yoga and its implications on mental health, how it can help in improvising the mental health. So it was a very nice and compact session and comprehensive in all terms. I would like to thank all the speakers, and I would like to thank the Mehek organization, the University of Pretoria, and JBI Ekurhuleni, and the JBI CPHR team for organizing this webinar. And we look forward to such webinars further on in the future, so that we can gain much more insights into such studies. Thank you so much. Thank you, everybody.
Thank you. Thank you so much.
Thank you so much.
Thank you and bye.
Okay, thank you, everyone. I think this is the end of the webinar. Hopefully, we are going to have more to come and more to collaborate. And we are definitely going to be learning from each other. Thank you so much, everyone. Goodbye.
Thank you. Goodbye.